evening with their presence. Your encouragement and support have truly inspired the participants. A sincere thanks to our honorable judges, Dr. Parveen Patan ma'am, Dr. Ava Kishti ma'am, Dr. Kajal Chauhan ma'am, and Dr. Pratiksha ma'am, who took their valuable time to evaluate the performances. Your presence added immense value and prestige to our event. We extended our deepest gratitude to our principal and organizing chairman, Dr. Subhash Khatri sir, organizing secretary, Dr. R.M. Singavelan sir, cultural committee head, Dr. Sheetal Gule ma'am, our faculty member and the entire organizing committee for their constant guidance, support and coordination throughout the cultural event. A louder cheer and deep appreciation to all our performers and participants. Your enthusiasm, talent and creativity have made this evening truly vibrant and memorable. We also acknowledge the dedicated effort of our technical team and volunteer who worked tirelessly to ensure everything ran smoothly. I extend sincere thanks to each one of you for making this event a grand success. Thank you all once again and have a wonderful evening ahead.
Thank you, Dr. Gitanjali. On behalf of Electrocon 25, we thank all the participants, judges, and the wonderful audience. Every voice, every beat, and every move will carry the same message that life is about balance. Good night and see you tomorrow for the wonderful and insightful session ahead. Participants and the delegates, please note that tomorrow morning sharp 8 o'clock, the breakfast will start and 8:45.
Very powerful talk. It lies hours of preparation, dedication and commitment. And for that, we are truly grateful towards yesterday's speakers. Your willingness to share your expertise reflect your passion for advancing knowledge and guiding the next generation.
Thank you once again for honoring us with your presence, for sparking meaningful discussions and for leaving us with valuable takeaways. We will feel fortunate to have learned from you. Without any delay, let's start this session with fun, knowledge and with a spark of your energy. Thank you.
Now, it is an honor to introduce an American board-certified physiotherapist with over 30 decades of practice. She is currently the head of Pelvic Floor Physiotherapy Unit at Jogo Health, specializing in cutting-edge digital therapeutic rehabilitation. A recognized expert, she has presented her work on pelvic floor dysfunction and digital therapeutics at prestigious international conferences like Digestive Disease Week, International Urogynecological Association, and American Urogynecologic Society.
The chairperson for this plenary session will be Dr. Nupur Kulkarni ma'am. She is Assistant Professor at Pravra Institute of Medical Science, and the moderator will be Dr. Pratiksha Lanke ma'am. She is Assistant Professor in Department of Sports Physiotherapy at Maharashtra Institute of Physiotherapy, Latur. We welcome Dr. Uma Venkatesa to take session on digital therapy for pelvic floor condition. Today, she will guide us into the world of digital therapy of pelvic floor condition.
In weak pelvic floor muscles, there is a load. And in tight pelvic floor muscles, increased tone, avoiding dysfunction, inability to pass urine, tight pelvic floor, vaginal muscles, vaginismus, broad categories, we focus on gastroenterology, urology and neurology. Dysenergic defecation, fecal incontinence, rectal prolapse, dysphagia, and urological conditions, urinary incontinence, voiding dysfunction, pelvic organ prolapse, chronic pelvic pain, sexual dysfunction, and neurological conditions like post-spasticity, focal dystonia, Parkinson's tremor, migraine, Bell's palsy, chronic low back pain can be treated using digital therapy. So how are we treating? First, these patients has to be evaluated properly in the form of SOAP format, subjective, objective assessment and planning. And a subjective, we take all the patient's history and outcome measures and then stop test and time taken to urination. All these scales we calculate. And then we do the objective assessment, JOGO EMG biofeedback assessment, per vaginal, per rectal examination, musculoskeletal assessment, and then formulate the goal and categorize them into weak pelvic floor muscles or tight pelvic floor muscles or combination of both, and then formulate the treatment plan of care. So in JOGO, we spend 1 to 1.5 hours of assessment, evaluation, and then send the assessment report to the referral physician and then give once a week for 10 weeks of therapy. On the 5th session, we send the midterm report to the referral physician, and on the 10th session, we do the re-evaluation and show the progress and then send the discharge summary to the referral physician. How does this work? It works on the principles of operant conditioning, trial and error learning. As you all know, we have learnt in the psychology, Ivan Pavlov's dog experiments. When the bell rings, the salivation starts. So the patient understands what is the wrong movement and then corrects using the device and then learns the right movement. With the practice makes perfect. So to create the neuroplastic change, the permanent changes are taking place when the electrodes are connected to the pelvic floor muscles. The afferent impulses are carried through the pudendal nerve to the frontoparietal region, and interpretation is carried on in the frontoparietal cortex, and then efferent impulses are carried, and then there is a long loop mechanism. So gut-brain interaction, bladder-brain interaction is going on in the pelvic floor dysfunction. So JOGO works through simple 5 steps: the electrode placement, the signal acquisition, feedback display, awareness building, and then the learning. As you can see in this video, there are different components of the EMG biofeedback device: adhesive electrodes, the sensors, the probe, rectal probe and vaginal probe. You can see this lady is having a wrist drop where the wrist muscles, wrist extensor, she is working in the live graph. You can see to strengthen the wrist muscles. Similarly, this is a incontinence patient where the vaginal probe is blue and then the red is the transverse abdominis. She is understanding how to do the isolated pelvic floor contractions through the process of elimination. So this is the step-by-step process. To learning, this is also another display of the advanced electrodes like cloth electrodes and thin film electrodes, which are imported from US, and it's very conducive for the perineal region, and it is very sensitive for the sensitive skin areas. This is the pad placement for the female, where you see for the urogenital problem you keep it on the paravaginal region, and for the anorectal issues we keep it on the perianal region for the extensor anal sphincter, external anal sphincter. This is for the male with urinary incontinence post RARP, above the genitalia in the ischio-cavernous muscles and below the genitalia in the perineal body. So we are all JCA certified, SEDESCO certified organization. We can use the device in the US and also in India, and we work closely with Mayo Clinic and Harvard in doing the advanced study. I wanted to share a male urinary incontinence case study post RARP. This is a 77-year-old male patient with complaints of leakage of urine after robotic assisted radical prostatectomy that he underwent in October 2024. Used 3 to 4 diapers per day, day and night. Leakage while coughing, sneezing, standing, from sitting, getting up from bed and walking. Disturbed sleep as he has to wake up to urinate approximately 3 times during night time. He underwent RARP, bilateral pelvic lymph node dissection, left inguinal hernia repair in October 20. Of life. These are the outcome measures we used: COSIAN, ICAQ, IAQ and 3AQ, pre-JOGO and post. From 2 by 10 it has come down to 1, from 12 it has come down to 5, IAQ has come down from 11 to 2, 3AQ has also improved. The frequency, daytime frequency from 3 to 4 times has improved 5 to 6 times, night times 3 times, it's come down to 1. An urge sensation was there always before JOGO, then it has come down to nil. Diaper 3 to 4 times per day to nil. So how do you interpret this? The graph is calibrated, the x-axis are calibrated in time, that is 30 seconds. Each square is 3 seconds, and y-axis are calibrated in millivolts second, 1,000th of the microvolts. The precision assessment is very good. So here the pelvic floor relaxation, before it was 10 to 12, then he was able to relax better after 10 weeks of therapy. And then the slow contraction type 1 has improved from 11 to 12 to 14 to 44 millivolts second. And then the quick contractions type 2 has improved from 11 to 12 to 17 to 30 millivolts second. So the patient is able to appreciate, aware about the pelvic floor contractions, and the patient has shown excellent progress with isolated contractions of urogenital muscles. For the past 1 month, the patient has had no leakage of urine during coughing, sneezing, no leakage in walking and sitting, no urgency, stopped using diaper. The challenges of conventional pelvic floor muscle training is difficulty in isolated pelvic floor muscles. In digital therapy we can do that. There is no proper assessment in conventional. Here we have a structured comprehensive pelvic floor evaluation. Non-quantifiable. Here it's quantifiable, you can validate, and limited supervision. Even for patients with remote patient monitoring, we can give the device and then monitor remotely. Lack of self-discipline. The adherence is very bad in the conventional, but here the patient is adhering and wanted to show the improvement week by week. So what gets measured gets improved. So with JOGO and without JOGO, there is a comparison. There is an active patient involvement here. Objective assessment is possible. Isolated muscle relaxation is there. We can track the progress and patient is motivated. Effectiveness of treatment can be validated immediately. So far, we have treated about 3,282 patients, out of which you can see urinary incontinence stops 1,082 and chronic constipation or dissonant defecation is next, that is 840. So overall, out of 3,000 plus, 1,500 plus are female patients, 800 plus are male patients, and pediatric patients are 200 plus. This is a testimonial of 72-year-old female from Nagarkoil, had urinary incontinence for 36 years. From 5 diapers, she has come down to 1 diaper within 3 months. So we have published in RCOG World Conference, and then AUX conference, Ayuga conference, and DDW conference with established data. Recently, we went to International Continence Society Conference in 2025, Abu Dhabi, from 18 to 28 September. We did the podium presentation on efficacy of digital EMG biofeedback therapy for post-prostatectomy incontinence patients with excellent results. This is our JOGO team. I'm very proud to say that we work in a collaborative manner with clinical team, patient care executive team, admin team, IT team to treat more and more patients all over India and also in US. Thank you for giving me an opportunity to speak in this conference. Thank you.
First of all, thank you so much, ma'am.
In Chennai, Mumbai, Kolkata, Delhi, Bangalore, Madurai. So we are fastly expanding, and this is a company for physiotherapists. We are giving more employment opportunities for physiotherapists. We are ready to hire more than 200 therapists all over India and abroad. So I'm so happy to share that we are doing more and more work in this field using the digital therapy.
Ma'am, is there any app for JOGO therapy or?
Can you come closer to the laptop and talk? I can't hear you.
Ma'am, is there app for JOGO therapy?
There is some echo going on. You were asking something. That male voice is very clear. Whoever is speaking, the MAEER Latur, that is very clear. Am I audible?
Yes, ma'am. Yes, ma'am. What is the cost of this equipment, ma'am?
Cost. Okay, you wanted the cost of the thing. First, we do the evaluation, and we have a package depending upon the geographical location. So, where are you located? Which part of India you are in? In Maharashtra. Consultation and 50,000 for the package. It is once a week for 10 weeks. And if they wanted to rent the device to practice, they can pay additional charge and practice on a daily basis. We can monitor their practice session through our expert tablet, through our view sessions. So the adherence is more, the patient can practice with the help of the device. We also give tele sessions remotely, so that patient doesn't have to travel all the way to the clinic at the comfort of their home, whether they're in a remote part of India or in abroad. They can log in from their home. We ship the device to their home. They can keep the device for 3 to 4 months and then practice. So in therapy, adherence is very important. Whatever we teach, they need to practice at home for 100% results. With the help of this device, we can facilitate that.
Thank you, ma'am. It was very insightful.
Can this be used for post-radiation therapy induced incontinence in rectal cancer, ma'am? Yes, we have used. Still, we need to do more studies because after prostatectomy, people undergo. Usually, they come 1 month after the therapy for the incontinence problem. Then, once it is in control, after 6 months, they are put on the radiation therapy. Similarly, for colorectal cancers, lower anterior resection, LAR, ultra LAR, and LARS syndrome, we treat patients. So, still we need to do more study about the radiation therapy patients post. Usually, we treat after the surgery, before the radiation and chemotherapy, so that they wanted to control the incontinence, whether it is a fecal incontinence or urinary incontinence. They want to control before giving the radiation therapy or hormonal therapy or chemotherapy. So we have to coordinate and work with the surgeon. What is the best time to give therapy? Usually we have a direct interaction with the surgeons so that we will plan the therapy accordingly. Yes, we can give treatment, but we have to be very cautious in post radiation because there are so many side effects like scarring and sensory issues, and then darkening of the skin, and then sensitivity issues. All those things are there, so we have to take that into consideration. Good question. Thank you.
Hello, ma'am.
Yes.
I wanted to ask, are there any specific parameters for genders?
Specific parameters before treating these patients?
Yes, ma'am. For both genders.
Leading to gender also, ma'am.
Yes. So we treat patients, male, female, girls, boys, and we train all the therapists. When we hire, we don't have curriculum, pelvic floor curriculum in our undergraduation or post graduation. So, or even internationally, it is certification only. Herman and Waller, section on women's, Australian therapists all give level 1, level 2, level 3 pelvic floor intensive training course. That's what we do for our staff. We give a 3 days workshop, intensive workshop with lecture according to the international standards with lab sessions. The males will be practice on male colleagues and female on female colleagues, so that should protocol for all these conditions: male pelvic floor conditions, female pelvic floor conditions, children pelvic floor conditions, girls and boys. Because minors and all, we don't do internal examinations. So there is international guidelines, universal guidelines which has to be followed. We were following American guidelines. We do have now Indian guidelines, IAP guidelines for pelvic floor, antenatal, postnatal, menstrual women. So we have formulated all those things. So we need to, the therapist should take a proper training, and then it will take at least 1 or 2 years to understand about pelvic floor. It is like a fellowship program or postgraduate program, where you need to be under a supervision of senior therapist, under the guidance. Then I'm sure you can treat these patients. We are offering those also. We can approach us, we sell the device and then train people, therapists, so that they can practice in their own institution. Okay. I hope I answered your question, Dr. Nancy.
My question to you is this therapy useful to carcinoma bladder?
What is that?
Carcinomal bladder, when person is getting clear bladder with the history of some of the other condition which is related to diabetes.
Yes. So it all individual based, and we need to closely work with the surgeon. And then when the surgeon refers these patients, we have to do the comprehensive evaluation. Yes, we have treated patients with new bladder. After the cancer bladder, they removed and created a new bladder. The patient was having voiding dysfunction, so we were working on that. So we were working on downward training and reverse Kegel training for the comfortable voiding of the patient. The patient was using clean intermittent catheter, and then they got rid of that and was doing voiding naturally. Okay, so it all
Okay.
individual based, and we need to work as a team: urologist, uro-oncologist, uro-gynecologist, pelvic floor therapist, and then
Plenty of
diabetologist.
specialists are needed in this
Yeah,
particular,
multiple
right?
specialty. We are
Because
part
the
of the
person
team.
is having history of even diabetes also, so medical correlation is
Yes.
needed.
So now we are very closely working with urologists, urogynecologists, gastroenterologists. So this is a
Hmm.
new field for physiotherapists, more job opportunities. Before it was only orthopedic and neurology and cardio, right? Now we have urology, uro-oncology, gastroenterology, colorectal surgery. The
Hmm.
expansion is going on more and more.
Hmm. Thank you, ma'am. Thank you so much for your fruitful
You're
answer.
welcome. Looking forward to treating all your patients as a team.
Thank you.
Any questions from audience?
Any more questions, Sangeeta?
Ma'am, just a minute.
Good morning, ma'am. Ma'am, hello. Ma'am, what are the main components of digital therapy used in pelvic floor rehabilitation?
That can interfere. For example, a pacemaker. If the patient is having a pacemaker and if you give something in the neck and shoulder area, it may interfere. So only these are the precautions. Most of the patients we are able to treat. We have not sent the patient back. Okay, so in rehab, we don't ever give up. This is the last place they come. We have to embrace them and then treat them and help them to improve the quality of life. So very limited restrictions are there. So these are the basic components in digital therapy, where it is user friendly, pain free, and superficial electrodes are there. And sometimes if you don't need the internal like probe, you can also accept that and give importance to their opinion. So definitely we can work and treat most of the patients.
Thank you, ma'am.
Virtual presentation. Thank you so much.
Thank you, Ma. I can log off. Okay. Thank you so much. Bye.
What an informative session. We sincerely thank our speaker for sharing time, experience, and wisdom with us. Now, let's move further. Now, I request Dr. Pratiksha Lanke ma'am to felicitate Dr. Nupal Kulkarni ma'am. Now, to lighten the session, I would like to call Dr. Kajal ma'am to come here and take over some games.
The thrill of competition, the energy of participation, and the joy of victory All of these come alive in the gaming arena of Electrocon 25. While the next session powers up, let's shift gears and plug into something fun. Once again, this is Dr. Kajal, up with more exciting games and prizes. Yes, it's time for a game break. Are you guys ready? Yes, that's the spirit. So one more time I would say, think fast, move faster, and if you blink, you are out. Here how it works. So, the next game is to identify physioscientist. So, it's time to test your scientific eye. Up next is our guess, the scientist round. A picture will be displayed on a screen. Look closely, observe and try to guess the genius. So, guess physiotherapy scientist. So, he's, wait. So, he's related with, like, he's a founder of electromagnetic induction and who established concept of electromagnetism. Who can guess? Any guesses?
Michael Faraday.
I request you to kindly come on the stage, please. What is your good name, please?
My name is Dr. Ansh. I am from Nagpur.
So, congratulations for the wonderful guess. With the correct answer, you have got a wonderful prize and a title of Genius Scientist Porter Electrocon 25. So, many congratulations to him. Cheers. I would like to request Dr. Pawan Kumar sir to kindly come on the stage and hand over the prize to the winner. Give him a big round of applause, everyone. Another game. Yes, still I am not hearing the sound. Yes. Okay, so it's quite interesting game. So the name of this game is mystery game. So welcome audience one more time in a game break. So detective don't give up now. Every mystery has a key and you are close to finding it. Think deeper, look closer. What are you missing? Okay. So here one question, one like clue, detective clue will be given and you have to find answer regarding, okay? So you have to read and you have to think, okay, who can be the, you have to find the answer, okay? Mysterious person who is. So, may I have the clue please? Oh. So, this is the clue. A detective who was days away from cracking an international oil smuggling ring has suddenly gone missing. While inspecting his last known location, officer find this note. Okay, so this is the code which is given in a number. So currently there are 3 suspects, Bill, John and Todd. So can you break the detective code and find the criminal's name? As quick as you raise your hand, you will be given a chance to speak. Who can decode it? Okay, can you please come on the stage?
Isha Patil.
Okay, and what is your answer?
Bill.
How?
My friend told me.
This is not the answer that my friend told. You should give explanation regarding, or you just have guessed it. Okay? Any other person who can help out? Yes?
And वो 8
What is your good name?
तेजस निमकर
Okay, and what is your answer?
बिल है
How?
8177 है ना, उसको उल्टा करे तो बिल होता है.
But still, what is a full sentence? Can you please tell?
बिल इज बॉस ऐसा लिखा है. बिल
And another, what is this 34? Okay, please, next slide, please. Next. Okay, so this is the answer and you are correct, but still, the sentence is incomplete. So, the first is bill. Okay, bill is boss, and what is the next? Answer is in that only. Bill is a boss of what? What is 34? Anybody can answer? Any guesses? Sorry? Yes? Okay, so I have to consider him as a winner. Please give him a big round of applause. He had a wonderful try. Okay, so the full sentence is, Bill is boss, he sells oil. Okay, so the question was related to the smuggling of the oil. So the answer is, he sells oil. Okay, so sorry, you cannot be given a prize. Your answer was partially correct. Okay, so wonderful. Cheers for him. He won the prize and he got a title of Master Detective Electrocon 25. I would like to call upon Zishan sir to hand over a prize to the winner. Everybody is enjoying? Yes? Any more games you want? Okay. So the next game will be after 1.
Requested to kindly contact to the scientific committee for submitting their presentations. Thank you.
And now, to keep the momentum going, we are honored to welcome our expert who has literally taken Indian physiotherapy to international sporting arenas, from the cricket field of IPL to the challenging ultra triathlon course of London. He has demonstrated that physiotherapy excellence knows no boundaries. His expertise, evidenced by his patent and startup recognition, shows us that innovations in our field can create both clinical impact and business success.
The chairperson for this plenary session will be Dr. Vishnuvardhan sir. He is professor and HOD in cardiorespiratory department at Ravi Nair Physiotherapy College, and the moderator will be Dr. Smitha Munde ma'am. She is assistant professor in Department of Neurophysiotherapy at Maharashtra Institute of Physiotherapy, Latur. Let's welcome Dr. Vaibhav Mahajan, whose session is on electrodiagnosis, a neglected domain in physiotherapy assessment.
First of all, I would like to thank Dr. Subhash Khatri sir and Dr. Singarvelam for inviting me here as a part of this wonderful conference and being here as a resource person for this one of the topic which is neglected yet connected very crucially with electrotherapy. From yesterday, we are hearing the many lectures about how the electrotherapy has taken over, how the AI has transformed the electrotherapy, what are the different new upcoming aspects of electrotherapy. But this is one of the topics that actually are neglected and we have to focus now onwards, otherwise it's going to be very difficult. So electrodiagnosis, a neglected domain in physiotherapy. So everyone knows exactly what exactly electrodiagnosis is. It's nothing but the specialized use of electricity to evaluate the neuromuscular physiology. The scope of electrodiagnosis is that it analyzes the function of nerves, analyzes the function of muscle and the neuromuscular junction, And if you see the relevance, it objectifies the assessment tool what we are using in our day-to-day practice as a part of our diagnosis, and it complements the clinical examination. It means we are not only relying on clinical examination, but to confirm the clinical examination, it also objectifies our assessment. Current status that despite important underutilized in physiotherapy, we'll see further how it is underutilized in physiotherapy. The definition of electrodiagnosis says it involves the recording, measuring, displaying and interpreting action potential which evaluates the central nervous system, peripheral nervous system and muscle. It helps to bridge the diagnosis or to reach towards the confirmatory diagnosis. It helps to plan out the prognosis or give the prediction about the prognosis, also the treatment planning as well. The indications of electrodiagnosis are, it involves the nerve injuries and neuropathies like diabetic neuropathy, muscle injuries and the myopathies like myasthenia gravis and all, neuromuscular junction disorders, localization and extent of lesion. Electrodiagnosis gives the exact location of nerve injury and what is the extent of lesion. Severity of grading, we are all ever knows about the Sunderland's classification, Sedon's classification of nerve injury, and prognosis, monitoring recovery after the interventions. Contraindication, bleeding disorders, open wound, burns, local infection, implanted device like pacemakers, stimulators, severe psychiatric illness, high risk of syncope and seizures. Types of electrodiagnostics tests, we are having the two classification. One we call as a conventional, one we call as a advanced. In conventional, we are using strength duration curve, Rio-based chronic C, Faradic galvanic test, reaction of degeneration, pulse ratio and accommodation testing, galvanic titanic test. Advanced, we are having electromyography, nerve conduction velocities, late responses and single fiber EMG. Single fiber EMG is a difference between regular EMG or electromyography. Electromyography utilizes the complete function of muscle, whereas single fiber EMG utilizes the function and the working of NMJ disorders or the NMJ. Physiological basis that we all know that resting membrane potential is one of the key concepts what we are going to assess here. So muscle and nerve, we know what are the resting membrane potential. Depolarization, here we are utilizing about the sodium influx and potassium efflux. Neuropathies, there is a decreased amplitude and slows conduction. Myopathies of velocities may be normal, but there is going to be the decreased amplitude. Degeneration, we can have the defibrillation potential and the positive sharp waves can be seen. Clinical value in physiotherapy. As we already discussed, it objectifies the diagnosis of neuromuscular disorder. So whatever the diagnosis, we are going to confirm with the help of physical test. Rather physical test, it objectifies and it confirms your diagnosis. It guides the treatment planning, how treatment should go in which direction, whether we are moving towards prognosis or we are having any hampering during our rehabilitation. It identifies the residual innervation. Rather than just asking about the cut of the innervation, it also gives the idea about what is the quantity of residual innervation. It predicts the rehabilitation outcome and it differentiates between neuropathy, myopathy and NMJ disorder, which other tests cannot do here. Now the main topic is why electrodiagnosis is neglected. That was just a background about what exactly electrodiagnosis, and from here the main topic is start why electrodiagnosis is neglected. The first thing is limited training and education. So till now we have seen our curriculum, UG curriculum, PG curriculum. In UG curriculum also we are having the introduction of electrodiagnosis. PG also we are having introduction of electrodiagnosis. We study about the EMG, NCV, late responses, everything as a theoretical aspect. Many colleges, it's sad to say, but many colleges still not having any EMG machine, MCU machine, so student doesn't have knowledge about how the machine looks like, what are the complete parameters of the machine that particular is having, what is the display, what the particular basis of that machine is having, how we can apply that, many of the student doesn't know. So inadequate curriculum exposure, physiotherapy program often only provide the basic theoretical introduction about electrodiagnosis and very to limited clinical application. If you say that zero clinical application can also be aspected here, because many of the colleges doesn't only provide the test of electrodiagnosis, only theoretical basis what we have seen in the classrooms. Lack of practical training. We only focus on theoretical aspect. In practical aspect, we are not having application or utilization of EMG and the NCV for the purpose of diagnosis. So what we are going to see from first year to final year, like special tests we are going to perform for the diagnosis, here electrodiagnosis we don't use. And the complex subject matter, yes. electrodiagnosis requires an advanced understanding of neurophysiology. In first year, we only study about the action potential, maybe some of the nerve and the other physiology, but from second year onwards, we forget. Even if I ask from audience now also, what is the action potential, what are the different phases of action potential, 90% of students unable to answer what is exactly action potential, what is Gibbs equation, what is Gibbs-Donon equation, Nernst equation, all that, and how we can apply clinically. So yes, we are staying away from the advanced neurophysiology, and that's why it's hampering our basic to advanced theory, and that's why it's hampering our clinical aspect as well. Perception as a physician's domain, yes, medical dominance we have seen from since ages that in many healthcare systems, electrodiagnosis testing is performed by the physiatrists and the neurologists. Physiatrists are nothing but the physical medicine and rehabilitation specialists. They use as a part of their domain, and that's why we are thinking it's not our domain. We are going to require a specialized certification courses, specialized workshop, because it's not been taught in our regular classes in the colleges. Legal restrictions. Many of the countries are having the regulatory bodies which doesn't allow physiotherapists to go for any of the insertional activities, and which doesn't allow any of the physiotherapists to go for the needle-based activities. That's why they are having their regulatory limitation. In India, we are not having that kind of regulation, but yes, to some extent, and the majority of many countries are having that regulations. So perception as a physician's domain failed us being a physiotherapy to acknowledge our own domain called as electrodiagnosis. Equipment and cost barrier, I don't think it's going to be a barrier. If you see the other medical specialists, for example, an orthopedic surgeon, they buy their X-ray machine which costs them around 10 lakhs, 15 lakhs, 20 lakhs. For physiotherapy, I don't think it's going to be the cost barrier, because a regular EMG machine in India can somewhere cost between 2 lakh to 5 lakh, including NCV and the separate biofeedback machine. Altogether, it's not going to cost you more than 8 lakh. But if you see about the medical practitioner, they buy their costly machine, they design their diagnostic setup, and they charge them separately. Why we are not doing that? We are just labeling it as a barrier, but this equipment and cost barrier is not our forte, is not for us. If some of the physiotherapy design or found their clinics, they order their matrix rhythm therapy, which can cost them around 4 lakh, 4.5 lakh. Why not diagnostic testing then? Time constraint and workflow. Yes, to have EMG, to perform ENG and NCV, we are going to require a little time than expected from the rehabilitation, but as per the new machine has come, it's going to reduce the timing. Again, it's not going to be the barrier in your clinic. If you are going to have the diagnostic setup like EMG, NCV, there has to be a separate physiotherapist who only is going to perform the diagnosis, and the separate physiotherapists who are going to perform the rehabilitation part. Again, I am not going to consider here as a barrier, rather I can consider here as a lack of awareness who should have a diagnosis and who should have the rehabilitation part. Low clinical confidence, yes, from first time we have seen that we are having only theoretical knowledge, not clinical application. We are labeling the lots of barrier, and because of that, UG students, PG students are having the underutilized clinical skill for the application of electrodiagnosis, and that's why they develop a low confidence to perform this. Again, misdiagnosis is one of the concepts. If you are not going to diagnose any of the part regularly, there may be chances the misdiagnosis will come, but if you do it regularly, this part will be negliged here. Under appreciation of clinical value, yes, we physiotherapists only undermine our own modalities. Whenever, nowadays we have seen that every day new modalities are coming. Matrix rhythm therapy came, we took that our hold, that saying that matrix rhythm therapy is a new part of electrotherapy, PEMF, whatever the new techniques are coming, we are taking our hold. But what about the old ones? We are not following, we are ignoring them, and that's why it's an under appreciation by our own physiotherapy committee towards the electrodiagnosis. Financial and the reimbursement challenges, yes, it's there for the physiotherapy part from previous part only, but nowadays many of the physiotherapies has been covered under the reimbursement part and the insurance as well. And if you going to utilize this as a daily, you need to write your recommendation letter to the insurance company that this is going to be our integral part, is going to require as a part of rehabilitation. If you do that, it's not going to be again the hurdle. The only hurdle what the insurance companies are having, lack of counsel. The insurance company has to recommend it by the council that these are our main domain, this has to be covered, then the insurance company will cover. Till now in India, there was no letter drafted from the council towards the insurance company. That's why the hindrance we have seen. But nowadays it has been solved to many extent. Many of the insurance companies like Aditya Birla, HDFC Ergo, ICICI Lombard, they have started reimbursing for the physiotherapy part as well, even for the OPD, even for the IPD. Interdisciplinary communication gap. Yes, we are having our own egos in between both medical faculty and the physiotherapy faculty. Medical faculty think that electrodiagnosis is not a part of physiotherapy. Physiotherapy think electrodiagnosis is not a part of neurologists and the physiatrists. They both should have the collaboration. Our domain should be very clear what part of neurology should play, what part of physiatry should play, and what part of physiotherapy should play. If we design our own boundaries, when, how, and who is going to act at which place at a given time, this hurdle can be overcome. Again, the fragmented delivery of the medical care we are having. Some part we are having only diagnostics, some part we are having only treatment, some part we are having only rehabilitation. So one person has to go everywhere rather than the person choose the treatment over the diagnosis. What is the global scenario about the electrodiagnosis? That in USA and Europe, initially performed mainly by the neurologists and the physiatrists or the physical medicine rehabilitation specialists, but now trained PTs are overtaken from last 5 to 10 years or last decade in USA and Europe about electrodiagnosis should be performed by the physiotherapists. India and Asia, it imbibe as a limited physiotherapist role. That is our mistake. We have not promoted electrodiagnosis as a part of our integral physiotherapy. Evidence trend that advanced PT practices advocates electrodiagnosis integration because many of the things which is not diagnosed by the regular physical examination, regular physical assessment, that has to be diagnosed by the electrodiagnosis and it has to be supported by the evidence base. Evidence-based application says that stroke rehabilitation, peripheral nerve injuries, radiculopathies, myopathies, NMJ disorders, sports injuries are initial days are diagnosed by the EMG. Like in stroke rehab, it gives a basic idea about whether the muscle going toward the spasticity or rigidity. Peripheral nerve injury, it gives the exact prediction about how the prognosis is going to be in future after post-repair or even before the repair. Radiculopathies, it confirms the level of injury as per the Sunderland's and Steddon's classification. Even it grades about the severity and depending upon the severity, it predicts the prognosis. It gives the differentiation between neuropathy, myopathy and NMJ disorder, and in sports, it can detect the subclinical dysfunction which is unable to detect as early as possible unless and until they are having the major or the grave injuries. Overcoming barriers, yes, curriculum reform. We are going to require a major curriculum reform at a part of physiotherapy university level and the council level to include a complete aspects of electrodiagnosis as a theory and the clinical skill as well. Workshop and certification, if our syllabus is not providing that part, again the workshop and certification has to be arranged, but that workshop and certification should be certified with credentials and should be valid all over the India or all over the globe. Affordable and portable technology already has come. Initially the EMG was only the insertional electrode were coming, now surface electrode are also coming, and in the surface electrode and insertional EMG we are having a exact calibration. Just only thing is that a good what we call it the model and the good company machine should be purchased. Policy advocacy, yes, we need to have our own policy to going forward with the electrodiagnosis. Who is going to have the electrodiagnosis testing? Who is going to have the conclusion? Who is going to certify this particular disease and disorders? Collaborative practice, we need to include neurologists, physiotherapists and PMR model together to give the collaborative effect of electrodiagnosis. Future of electrodiagnosis in physiotherapy says about integration into rehab protocol, portable and AI assisted systems is going to include it. Tele-electrodiagnosis is one of the part which is coming nearly and has to be is already patented by the USA. Research in neuroplasticity and sports and the patient-centered precise care about the electrodiagnosis and its further part into the rehabilitation. The conclusion of this that electrodiagnosis, it's a bridge between clinical examination and the pathology. If you want to confirm your diagnosis, we need to have electrodiagnosis testing to confirm at a higher level. Neglect. Any of the neglect toward electrodiagnosis is going to call it a missed opportunity. And as the Khatri sir always says that if we are not going to use it, we are going to lose it. And if we are going to lose it, someone will use it. And that's already happened for the electrodiagnosis. As a physiotherapist, we are not using electrodiagnosis as a part of our diagnostic system. That's why neurologists, physiatrists, and the physical medicine and rehabilitation specialists have started using this as their domain, but initially it was our domain. We should understand this very carefully, that which is our domain and what the domain we have to protect by which level. Call to action that we need to learn about electrodiagnosis, we need to apply electrodiagnosis from UG level, PG level, and we have to advocate electrodiagnosis as a part of our regular diagnostic tool. Expand scope and collaborate, that we already discussed. The outcome is going to be the better diagnosis, treatment, and the patient lives. If you are going to hit your diagnosis exactly at the point, a short term of rehabilitation or the treatment will gain you a large knowledge to the patient. Why we chose this topic? When I was discussing with Khatri sir that I am going to have this topic and it's going to align with the theme. The theme says that innovation, evidence, and beyond. Innovation, that every day new innovations are coming in electrodiagnosis. We are neglecting that, that's the second part, but for the rehabilitation, for the treatment, as a part of physiotherapy, we are having a major problem in ourselves, because every day when new treatment comes, we try to apply, try to imbibe that new treatment, but we forget about the diagnosis. Innovation has to be there for the part of diagnosis separately and the part of rehabilitation separately. Evidence, whatever the testing we are having as a part of physiotherapy, we need to generate a scientific evidence based by applying to patients. We need to collect data, and using that data we can say that this electrodiagnostic has been confirmed in this particular topographical region for the Indian population and beyond. Here we are having our main lecture that we need to think electrodiagnosis beyond our scope. How beyond our scope? That using this platform, I would like to suggest that Khatri sir is also there, our two international speakers there, Christian Ray and the Warren sir. We should have something called as International Electrotherapy Forum. We will form that International Electrotherapy Forum. Under that International Electrotherapy Forum, we should have something called as electrodiagnostic part and the electrotherapeutic part. And that electrodiagnostic part, we need to certify as a whole through WCPT what are the diagnostic testing part of electrotherapy we need to certify, and what are the treatment and the rehabilitation protocol we need to have as this part. So that's what we are standing here as a beyond. And as a part of physiotherapists and as a principal of one of the renowned college, I would suggest to everyone who is sitting here that rather than only having the clinic, someone should also have the diagnostic center, which is specifically run by the physiotherapists. You have seen the medical colleges, they are having their own diagnostic center. Right, all the medical colleges you take, dental college, they are having diagnostic center, medical college, diagnostic center, Ayurvedic college, diagnostic center. What about physiotherapy? There is no diagnosis part we are playing at our role. So every physiotherapy college should establish a one diagnostic center where they will be having their diagnostic part as a EMG, NCV, biofeedback, special test performance, whatever the things we are going to perform as a part of diagnosis to confirm the diagnosis of physiotherapy diagnostic center should be established, and that's what we are talking about the beyond in our this particular conference. Thank you so much. If anyone is having any questions regarding electrodiagnosis and why it is neglected in our Indian scenario, in the global scenario.
Hello. Good morning, sir.
Good morning.
Sir, my question.
It is given in Indian scenario that we are not having any boundaries that we cannot use, but some of the other medical specialists like neurologists and the physical medicine rehabilitation, they claim that electrodiagnosis is their part. Why they claim that? Because as a part of physiotherapy, we have neglected. As a part of UG, in third year, we are just having what is electrodiagnostic, what is EMG, what is NCV, that's it. We are not having clinical application. Many of the colleges are not having the machine as well. So we cannot have the exact utilization of that diagnostic part. This is a machine, this is the interface, this is what we call as the panel of the machine. These are the buttons we are having. This is the types of electrode we are having. So if you are not utilizing it as a UG part, it will be very difficult for the PG. Even for the PG, we focus on the synopsis and the dissertation. We are not utilizing it for the complete part of the patient diagnosis, and that is following that there.
Thank you, sir. Sir, thank you, sir. It was very informative lecture. I just want to know your opinion about the needle EMG, as it is an invasive procedure. So, can India do it like a needle EMG officially? Because I have discussed with Dr. Kishan, sir. So, in Philippines, it is they collaborate with a neurologist or a medical practitioner for needle EMG. What is the status in India? Can we officially do the needle EMG?
Yes. See, needling in India is officially as well as unofficially. 90% of the population who pass their UG and the PG, they do their needling course, right? If they are doing their needling course and they are inserting needle into the muscle, nerves and the tendons, it is already official because they are having their certification. The official part, we are talking here about the curriculum. This electrodiagnostic testing, whether it is insertional or the surface electrode we are using, has to be taught in our own curriculum certified by the university. If university allows us electrodiagnosis to be a part of our physiotherapy, where the part comes as a legality, it's our own domain. Only thing is that we are only depreciating ourselves that this is not our domain. Why this is not our domain? Because we are having fear of failure. There might be a misdiagnosis. Yes, there might be a misdiagnosis. All the medical specialties who perform their surgery, first surgery is not excellent. After 10-15 surgery, they can do their precise surgery. Similarly, there might be a chance of misdiagnosis, but because of misdiagnosis, you are not going to have here any serious illness or very serious damage to the patient, right? So it is legal. It is already in our syllabus. We are underutilizing it. The syllabus reformation committee at the council level and the university has to take a stand to make it legalized furthermore.
Thank you, sir. One more question.
Allow me to share with you, I do agree with you, because as a PT, we need this kind of performance and this kind of knowledge. But for the curriculum itself, for 4 years, students study, I understand that it's kind of packed because we need a lot of skills. So from my point of view, this part should be another step. After we graduate undergrad for PT, we got the special training because we need in-depth of knowledge. We need skills to see patients first. Nowadays, in Thailand, SD curve, EMG, the student study it, but not in depth. But for SD curve, they have to, we have the competence that PT must be able to do SD curve. But when they do the clinical practice, they don't use it. Of course, limitation of time when they take care of the patients. That is the first thing. So from my point of view, the next step of the curriculum to be like specialist training might be better, might be a good choice for us as a PT. After we have like basic quite properly, that's the first thing. And the second thing is the needle EMG. Let's say like in Thailand, we are not allowed to do it because PT we will treat a patient with non-invasive. But anyway, for surface EMG, we still can use it. And if we can use that, we still need to train our students to use that part. And also nowadays we use like ultrasound imaging for diagnosis. PT don't use it for diagnosis. We use it for evaluate and see the progress of the patients. It is, from my point of view, it's not much different. It's a way to communicate between PT and other professional, which is good. So we should emphasize this, because I heard a lot from Western side. They try to ignore the electrotherapy. They try to ignore the electrodiagnosis, which I don't understand why, but they say that it lacks of evidence-based practice. But when you dig down into the information of the evidence-based practice, even the textbook is one of evidence. Expert opinion is one of evidence, but it's not a good evidence, all right? But when we read through all of the paper, let's say like ultrasound therapy. I just discussed with a Christian. We can see that the effect of treatment is not well at all in a lot of papers said like that. But when we read the paper, you must dig down into the parameter that they use, the condition that they use. Even the appraisal tool for the paper itself, it doesn't go deep down into the detail of the parameter in the treatment. They just ask for showing the parameter. But for PT, we know that several parameters are crucial. So when you read the paper, we may have to think carefully that we're going to believe it or not. So back to the thing that I would like to share. I emphasize you guys to have the special training. I do agree for the certified. And if you can have, like I said yesterday, you can have a club or association as an electro association for PT, and then you can certify them. I don't know you can do it or not. You may have like those kind of thing, and you may like make collaboration with an international.
Saraswati Iyer Madam, Mrs. Yardi and Mrs. Edgunji, my guide. We used to do needle EMG, nerve conduction studies every day in the morning and post-lunch session to 2 patients. We used to get referral from orthopedics department and neurology department. But after few years, that practice is totally shut off, and now doctors are only doing neurologists, and there are electrophysiologists who are doing and generating the reports. So ultimately, if we are talking about electrodiagnosis in physiotherapy, it will be amount to only surface EMG and kinesiology EMG, which will be used to train the muscles, to re-educate the muscle, giving biofeedback and all. If you are going to do electrodiagnosis with needle EMG, it has to be reported on the paper and generating the reports, which you don't have authority. And as Dr. Warang said, it is the invasive treatment which is not certified for physiotherapists legally by state and central government authorities. Okay?
Sir, let me clarify you one thing here, that if you see the NCAP draft, in NCAP draft, it has been mentioned that some of the invasive procedures are allowed for the physiotherapists from now onwards. So if initially it is given, initially you perform your EMG, right? That is the problem of physiotherapy, that we don't generate a documentation. Even if we are going to perform the SDC, strength duration curve, we don't perform the documentation. We need to have documentation for each and everything, what the test we are going to perform, whether it is the Faradic galvanic test, whether it is SDC, whether it is NCV, EMG or anything. We need to have a documentation to provide that this has been certified. And wonder why physiotherapists are not certified, because the previous definitions of WCPT, IAP and the State Council has not mentioned. But if you see the recent draft of National Council for Allied and the Healthcare Profession, they have mentioned that invasive procedure, even some of the injections are allowed for physiotherapy under the certification courses and workshop. That's why it is mentioned there that till now it has been ignored as a part of physiotherapy, but this is our domain. First thing is that we all are saying that we should evaluate. Unless and until you cannot diagnose, you are not entitled to evaluate as well, because the diagnosis is your first part. If you see the definition of WCPT, definition of IAP, definition of council, everywhere it is written physiotherapists are entitled to diagnose. And to diagnose, we need to have certain equipment. Without equipment, we cannot have a diagnosis. Just doing the physical examination, we cannot reach toward the diagnosis. It's just an examination. To confirm your examination as a part of diagnosis, we need to have a diagnostic tool. And that's what we are talking about here.
Sir, with the permission of Vaibhav sir, students are overburdened with lot of things to be studied. Okay, that is the first thing. So we cannot have multiple exams at multiple times, right? Because it is already putting lot of stress onto the students. We have to look into that. Number two, as far as the electrodiagnosis part is concerned, it is not that it is not there in our curriculum. We already have it in our curriculum, and ours is already a competency mode curriculum. So already the competencies have been tested once the exam is taken. That is the second point. The third issue is in regards to certification and all. I have here multiple principals sitting over here. So I'm giving an open opportunity for all of you. You can start the certification courses in maybe EMG, NCV with a collaboration from a neurologist also. We can do that because now we are going for integrated holistic approach at the university level also. The reason why I'm telling you this is openly here is my vice chancellor is from pediatrician. She's a pediatrician. My pro vice chancellor is a Ayurveda person. My controller of examination is from forensic medicine. So already we are doing lot of integrations. So if you come up with this, so maybe we can have as a certificate course for 3 months, 6 months. We will create online module platforms. We have the people for that. And then slowly and steadily it can come. The thing is, the students have to be interested to take up this course. So as a teacher, how much of interest we are able to generate in the student, it is equally important. But पिछले 25 साल का मेरा अनुभव ऐसा है कि when students take an entry, they are only concerned about getting a degree. They are not interested in getting any other additional certifications. This is the fact of life. And maybe when they come into the real life practice, then slowly and steadily they start understanding what is this. So this is my take on this. Thank you so much, sir.
Thank you so much, sir, for emphasizing what we are talking about, the beyond here. Again,
are not really on to medical diagnosis, but rather we are on to assessment and evaluation so that we can come up with findings. So actually in the Philippines, what we do is because of that problems with terminologies, instead of using electrodiagnosis, we rather resorted to the electrophysiologic assessment terminology. Because under the electrophysiologic assessment, which we adapted from APTA, it clearly identifies our role as a physiotherapist, that our focus is not really on the medical diagnosis, but rather on the evaluative aspect of what we are doing. So I think the things that we still want to advocate when it comes to electrophysiologic assessment is still there, but it's just a matter of also using the terminologies that we have. So maybe that's one thing. And maybe it was shared a while ago that for the needle EMG, yes, in the Philippines, we are not yet allowed to do that. But for the surface EMG, physiotherapists are already doing that. But if we are collaborating with a doctor, we are actually allowed to participate in any needle EMG activities for as long as we are in a collaborative setting. But usually we do that on a higher level, which I believe with what Sir here mentioned a while ago, probably not yet at the bachelor's level. We usually incorporate that to higher year levels because there are so many things already that we want to include and incorporate in the curriculum at the bachelor's level. So what we did, we included that as part of our advanced training for our physiotherapists in the Philippines. So probably that's just a sharing that I could make. So thank you.
thank you so much, sir, for sharing. That's about the difference between country to country what we are having. I'm giving my opinion regarding to Indian scenario. Why the Indians, at least you are having neurophysiological assessment. Our physios are not doing that also. Our physios are blindly accepting that this nerve injury patient has come. They just move your arm, unable to move, they diagnose it's a galvanic current going to require, and they start with their treatment. So unless and until we don't start from basic level, it is difficult to reach at the advanced level. And as per the NCAP and the council, we can definitely have the amendment that at the Indian level. Thank you so much.
Sharing your insightful knowledge with us. Your insights have provided us with valuable perspectives and inspired everyone present.
I would like to request Dr. Vishnuvardhan sir to kindly felicitate Dr. Vaibhav Mahajan sir. Felicitate Dr. Vishnuvardhan sir. Now I request Dr. Atif Ansari to felicitate Smita ma'am. Let's move from papers to play. I would like to hand over the mic to Dr. Kajal Chauhan ma'am to carry on with the games session.
How is the energy? Not audible? Ready for the game break? Okay, that's a spirit. So it's time for a fun and exciting round. The name of this game is Quote the Picture. So here you don't need to use like, it is not like a one single is a correct answer. You can just have your own ideas. So one picture will be displayed. You can share your thoughts, okay? Anything you can say. So the wonderful answer and wonderful quote will be given a prize. Okay, so get ready for it. So it will show you an interesting picture and your task is to come up with the best or funniest quote that matches it. So be creative and even dramatic, anything goes. Remember, there are no wrong answers here, just lot of fun and laughter. So put your thinking caps and get ready to share your quotes. Okay, may I have the picture, please? So who wants to share your quote? Anything that comes in your mind, you can share. Any guesses? No hands I'm seeing. Yes, sir. Sir, I request you to please come on the stage. Okay, yes.
There are no boundaries to learn anything new, and the research is like an ocean.
Wonderful quote given by sir. Cheers for him. Give him a big round of applause. Sir, can you please come on the stage?
My name is Mr. Vaibhav Dolas. I am working at All India Institute of Physical Medicine and Rehabilitation, Haji Ali, Mumbai, as a lecturer in physiotherapy, and I am MUHS recognized PG teacher for musculoskeletal physiotherapy. Thank you.
Sir, so you won a prize for your wonderful quote given by you and a title of Innovative Mind, Electrocon 25. Cheers for him. I would like to call upon Dr. Singarvalan sir to hand over the prize, please. Available. I would like to invite Dr. Khatri sir. I would like to invite Dr. Vijay Pandita sir to hand over the prize. Oh. Sir. This game is quite interesting. Okay, so the name of this game is Identify Heroine in a Male Version. Okay, so it will be going to be funny. So you have seen your favorite actress in a game, glamorous looks and dazzling styles, but have you ever wondered how they will look in a getup of men? Okay, so here one picture will be displayed. So it will be a male version of a female actress. You have to identify as quickly as possible. May I have the picture, please? Yes. Okay. So the girl in the white shirt, please. Yes. Can you please come on the stage? Yes. What is your good name?
Madhura Kale.
What is your answer?
Deepika Padukone.
So, any guesses? The answer is correct or not? Yes? So, wonderful answer given by the participant. Cheers for her. And with the correct answer, she won a prize and a title of Best Face Decoder Electrocon 25. So, give her a big round of applause, please. I would like to invite Pramod sir, kindly hand over the prize to the winner. Cheers for the participants, please. So we are currently in orbit and preparing for the next plenary session. Stay tuned for more games, laughter, entertainment coming in your way. Keep smiling and never trust a photo again. Okay? So I will come back after next plenary session. Okay? See you guys. Next session, we welcome whose expertise in sleep medicine has awakened new possibilities in neurological rehabilitation. His international recognition at the World Sleep Congress in Canada proves that innovation Indian research can make global impact. As someone who has dedicated 13 years to our hosting institution, Maharashtra Institute of Physiotherapy, Latur, he brings both international perspective and local understanding to our conference. His book on restless leg syndrome shows us that even the most challenging condition can find solution through dedicated research.
She is a principal and professor from Sanchiti College of Physiotherapy, Pune. And moderator will be Dr. Mohammad Zishan sir, assistant professor, Department of Musculoskeletal Physiotherapy.
We welcome Dr. Suresh Kumar sir to express his word on evidence-based functional electrocytical stimulation protocol, improving outcomes in motor relearning.
Respected Dr. Subhash Khatri sir, Principal, MIP College of Physiotherapy. Respected Dr. Singaravelan sir, Organizing Secretary, MIP College of Physiotherapy, and my colleagues and my students. I have spent 13 years in this institution, so I am very happy to come back and present a topic here. Thank you. Thank you for giving an opportunity here. So today my topic is evidence-based FES protocol, improving outcomes in motor learning. Slide. Either. Functional electrical stimulation has emerged a valuable therapeutic tool in neurorehabilitation. It facilitates motor learning in individuals with neurological conditions like stroke, spinal cord injury, traumatic brain injury. However, inconsistent outcomes across the clinical setting highlight the need for standardized evidence-based approach. This presentation outlines the development and clinical implementation of evidence-based FES protocol aimed at optimizing the motor recovery by integrating a current research, neurophysiological principles, and patient-centered strategies. This protocol emphasizes task-specific training. So you are giving a task and your intensity modulation. So you are going to increase the intensity and timing of the stimulation relative to the voluntary effort and targeted muscle group selection to maximize the neuroplasticity and functional outcomes. So general FES protocol steps. So first step is patient assessment. A comprehensive initial assessment is very much critical to determine the suitability and guide for this treatment. So you have to establish the baseline function like current motor function, range of motion, strength and walking speed to track progress. Indication and contraindication of FES. Indication: muscle weakness, paralysis, limited movement from an upper motor neuron lesions such as stroke, multiple sclerosis, spinal cord injury or a brain injury, traumatic brain injury. Contraindications are people with cardiac pacemakers or other implanted electrical devices, active cancer in the area of treatment, adaptive deep vein thrombosis or thrombophlebitis, damaged or at-risk skin such as open wounds and pregnancy. These are the indication and contraindication of FES. Motor points. So we all know what is a motor point. So you have to locate the optimal electrode placement by finding the motor point. This is a position that produces the strongest and most isolated contraction with the least amount of stimulation. Parameter customization. So you have to set the parameters first. After finding the optimal electrode placement, the therapist sets individual stimulation parameters. The goal of this stimulation is to produce smooth, comfortable contraction for functional movement. So first one is pulse frequency. Typically it ranges from 20 to 60 hertz. So for 40 hertz stroke patient we will use 20 to 25 hertz initially for spinal cord injury patients to minimize fatigue, and higher frequencies up to 60 hertz especially for higher output when we are giving a FES cycling or from sit to stand position. Next one is next parameter is pulse width. Pulse width or a duration is the length of each pulse. Longer width recruits more and deep fibers at the same current, useful when motor current is very poor. It depends, you can select the pulse width. The typical range is 100 to 35 microseconds, or you can use 25 milliseconds commonly used. 250 milliseconds we commonly use. Amplitude and intensity. So this amplitude determines the force. So increase until desired motor response or a functional movement will be produced without intolerable pain for the patient. Next one is the waveform. It may be a monophasic or a biphasic waveform. Most surface FES uses biphasic rectangular pulses to reduce net direct current and skin irritation. Next parameter, on and off timing, we call as duty cycle or a RAM. It controls functional timing, especially gait on a swing phase, and it gives comfort. Use RAMs 0.52 seconds for a smooth contraction in a functional task. So you will be giving 1:3 or a 1:5. Means when you are operating this, 10 seconds will be the on where the stimulation is given, and 30 to 50 second rest will be given. This rest period will allow recovery and prevents fatigue. Electrode size and placement. So always we prefer the electrode depending upon the size of the muscle. You can say it depends upon the number of motor unit need to be recruited and also the comfort of the patient. So when you are giving a larger pads, lowest current density and it needs a broader recruitment. So multi-pad electrodes can be used to improve greater selectivity. Next one, after the parameters, we are going to see the functional activities what we will use. The training involve real world activities such as for the upper limb, reaching for or grasping object, example holding a cup or a pen, or for lower limb, you can give walking, ankle dorsiflexion for foot drop, then standing from a chair or a strenuous activities such as cycle. Next one, high repetition practice. Many evidence-based protocol call for numerous repetitions. Continuous repetitions are needed for functional movement during each session to maximize the result. Next one, duration and dosage of FES. The total duration and frequency of FES session affects the outcome. So session length, a typical session lasts from 20 to 45 minutes, including the setup and the training. So total hours needed for the improvement. Studies shows clinically significant gains after 20 to 48 hours total hours of FES therapy, often delivered over 8 to 14 weeks. So a minimal FES, you can give the treatment for 8 to 14 weeks for a better result. Progression. As the patient voluntary control improves, so when the patients, you are getting the improvement, FES intensity is gradually reduced and eventually you have to phase out of the FES. Gradual reduction, when you are going to reduce that? As a patient voluntary motor control improves, so if it reaches a score of at least 3 out of 5 of manual muscle test, then you can gradually reduce it. So you have to gradually reduce the intensity of FES and increase the patient contribution. Targeting, so once you are phasing out, you have to relocate the FES channels to other weaker muscle to address new or persistent deficit. So therapist feedback, what therapist we should give, we have, as a therapist we have to give feedback to the patient. The therapist provides precise verbal and manual feedback to ensure the quality and as well as the correctness of movement. The type and the frequency of feedback should increase or should decrease over time as a patient skills improve. So when the movement he is doing correctly, then you have to reduce your inputs. Follow-up and monitoring. Ongoing assessment ensures continuous progress and safety. Regular reviews, so you have to give more follow-up recommended for this, for the patient. Outcome measures, you can use validated scales tools like Fugel-Meyer assessment for stroke or any other functional ambulation test. Skin checks, so inspect the skin under the electrodes for any irritation or redness after each session. Independent use, train the patient to independent setup. So for a home use, so you can give the stimulator with the patient and he can set up by his own and he can do in the home itself. So it maximizing the carryover effect outside the clinic. Example for FES, we all know. So foot drop for in stroke patient. So the muscle targeted will be the peroneal nerve which activates the tibialis anterior muscle to lift the foot. The trigger, you will keep the stimulation. The trigger will be a heel sensor, it will be in the shoe triggers. It will stimulate during the swing phase of the walking. So functional tasks, what functional task you will give? The patient practices walking which helps them achieve a more natural gait and improves walking. These are the example of FES. Next one, important one, neurophysiological principles of FES. So FES relies on several neurophysiological principles to restore or improve movement in individuals with neurological impairment. So it works by artificially, we are giving an external stimuli. So it works by artificially activating motor and sensory nerves to generate functional muscle contraction, and it promotes beneficial changes that happens in the brain, CNS and spine. So it happens in the CNS, a process known as neuroplasticity. First, neuromuscular activation. So targeting the nerve fibers. FES device delivers electrical current via electrode placed on the skin, targeting the peripheral nerves that supply to the muscle. The current depolarizes the nerve membrane. First it depolarizes the nerve membrane, triggering an action potential that travels along the nerve action to the NMJ. So everyone we know. Recruitment of muscle fibers. So once it reaches the NMJ, the sufficient stimulus is applied, the action potential causes release of neurotransmitter at the NMJ, leading to muscle contraction. So there is a differences between the voluntary contraction and as well as the during FES. In normal voluntary control, smaller, more fatigue resistant motor units, type 1 fibers are recruited first. Whereas in FES, when you are giving a stimulation, it tend to recruit larger, more powerful, but also more easily fatigued motor units. Type 2 fibers will be initiated first. So we have to be very careful with that. Tetanic contraction. The frequency of electrical pulses determines the quality of the contraction. So low frequency produces individual muscle twitches, while higher frequency, when you are giving a higher frequency, typically 20 to 50 hertz, causes the individual twitches to fuse together. Continuous you are giving, it gives a smooth, sustained contraction known as tetanic contraction. Next one, sensory feedback. Peripheral feedback. When FES causes muscle to goes for contraction, it provides provides direct proprioceptive and sensory input. Receptors in the skins, joints, muscles send signals to the spinal cord to the brain, providing essential information about the limb movement and as well as the position of the joint. Next one is role of learning. By sensory feedback is very crucial for motor learning. By providing the nervous system with the concrete, repeatable, you are giving a continuous contraction, repeatable information about the functional movement, FES helps to re-establish and strengthen the brain memory of how the movement feels. This is especially important when original descending motor commands from the brain are damaged or incomplete. Next one is neuroplasticity and cortical reorganization. For a long-term recovery of voluntary function, the carryover effect, the FESs must induce neuroplastic changes in the brain and as well as the spinal cord. First one is Hebbian learning. So Hebbian learning, FES therapy that involves patient voluntary attempt to move at the same time as the electrical stimulation leverages Hebbian learning. The neurons that fire together will wire together. This is Hebbian learning example. Neurons that fire together, it will wire together. The simultaneous descending signal from the brain as well as ascending sensory signal from the stimulated fibers strengthens the synaptic connections between them. So it strengthens the synaptic connection from them. This is called Hebbian learning. Next one is cortical reorganization. Repeated pairing of intent, that means patient is preparing the mind, he has to do the movement. Intent and action produced by the stimulation. Repeated pairings of intent and action can lead to cortical reorganization, where brain's motor and sensory maps are rewired. So the functional MRI studies have shown that FES can increase activity in the sensory motor cortex on the side of the brain opposite to the affected limb. Next one is spinal circuit modulation. FES can also influence neural circuits at the spinal level. For example, it helps to reduce the spasticity by inhibiting the spinal muscular reflex excitability and increasing the reciprocal inhibition over time. So this will reduce the spasticity as well. So the biggest problem is while we are giving the stimulation is the muscle fatigue. So how we will overcome the limitation? Muscle fatigue. FES causes muscle fatigue more rapidly than voluntary contraction due to its non-physiological recruitment order and synchronous activation of muscle fibers. So various research are going on. Research is exploring methods to navigate this, including optimizing the stimulation protocols. So they are continuously changing the stimulation protocols and using techniques like EMG triggered systems that only stimulate when the patient initiates the movement. Adaptation. This is also one more problem with the giving a stimulation. The control system of FES can be adapted to overcome challenges like muscle fatigue and unpredictable patient response during the treatment. So often patients in a contraction, it will become reduced. For example, modern FES system can detect the drop in muscle force and increase stimulation to maintain the desired movement as a key feature of closed loop control. So automatically it senses, the sensor will sense and increase the stimulation. Clinical evidence and efficacy. So stroke rehabilitation. Studies continue to show that there is a effectiveness of FES for improving upper and lower limb function after stroke. Neuroplasticity and carryover effect. The significant focus is on the carryover effect, where functional gain persists even after it is turned off. So when you are giving a stimulation, the movement will be produced. But after if the patient goes home also, he has to produce the movement. This is called as carryover effect without the FES stimulation. Research suggests that FES triggers neuroplastic changes in the CNS system, which keys to restoring voluntary motor function. Current research in functional electrical stimulation. FES is advancing in several key areas, including enhancing the therapeutic outcomes, developing more sophisticated wearable devices combining FUSs with other technologies as well. Major research themes focus on improving motor control and function for conditions like stroke, spinal cord injury, multiple sclerosis, cerebral palsy, traumatic brain injury, etc. So, technology-driven FES. So, what are the modern technologies there? So, nowadays, surface implantable electrodes are there. It delivers it delivers stimulation very accurately. It helps restoration of limb movement. Another one is wearable sensors like IMUs and EMG. It detects motion, muscle activity, or during the gait phases. It helps in adaptive stimulation and timing. Then brain-computer interfaces, BCI, VCI, translates brain signals into stimulation commands. So it helps in cortical reorganization post-stroke, robotics and exoskeleton. So combine movement assistance with stimulation. FESS assisted gait training we can use. AI and machine learning algorithms. Nowadays auto-adjust stimulation parameter. It helps in auto-adjust the stimulation parameters. So it helps in personalized FES protocol. Virtual reality. Provide immersive motor learning feedback and it helps enhancing the neuroplasticity. Thank you. Hope this will be useful for you people. Thank you. Thanks so much.
Good afternoon, everyone. Thank you, Khatri sir, for giving me a chance to chair this session. A nice talk delivered by Dr. Suresh Kumar sir. You very well covered the whole aspects, right from the parameters to the mechanism of action, as well as how neuroplastic principles are aligned with FES, plus the evidences that suggest, and the cherry on the cake was AI utilization with FES. That was really amazing. I just want to know only one thing, that we at Sanchati, we are definitely using FES for the treatment, and we are getting amazing results for CP kids as well as stroke patients. Are there any protocols or any things for spinal cord injury for their trunk improvement utilizing FES? Because what I have studied or I have searched, spinal cord injury is an area, especially the trunk, where less evidences are present. So if you can highlight on that specific thing.
Especially in spinal cord injuries, the problem with the spinal cord injuries, the muscle will go for fatigue zone. So you have to reduce the frequency and the intensity. You have to use less. So automatically the improvements will be more.
Thank you, sir.
Any questions from audience?
Yes.
Good morning, sir.
Good morning. Good morning.
My question is, what are the current evidences for FES to improve the motor function in post-stroke and post-spinal cord injury?
So if you analyze FES nowadays, there are plenty of evidence are available on the net. Mostly, more studies are conducted on FES only. Thank you.
Thank you, sir.
To just add on to Suresh sir's answers, stroke, upper limb and lower limb functions, moderate to strong evidences are there. Multiple sclerosis, you have strong evidences. If we come to Parkinson's for bradykinesia, we have moderate evidences with that.
My question is, actually, your session was very good. I just need to know, are there any standardized assessment protocol to check the progress after FES?
Actually, there is a separate protocol is available. I will share at this end of this session.
Right. Thank you so much.
Thank you.
And the valuable knowledge you have shared will surely inspire all of us and spark new ideas. Now, I would like to call upon Dr. Radha Bhattad ma'am to kindly felicitate Dr. Suresh Kumar sir. request Dr. Singarvelan sir to kindly felicitate Dr. Radha Bhattad ma'am. Dr. Radha Bhattad ma'am. To kindly felicitate Dr. Jishan sir.
Oh wait, did we just meet or did my brain take a break? I nod, I smile, I say something cool, then run to a break. It's my networking tool.
Chill wish, it's time for a break. Yes, the only therapy that works without electrode and networking, and the only place where flow means conversation, not electricity. We will resume in 15 minutes with our next exciting offline scientific session. Don't be late. Thank you.
Electrocon 25, we extend our heartfelt greetings to one and all present here. It is our profound pleasure to welcome you to this scientific session.
Absolutely, Vishakha. In this session, we have a total of 10 presenters, each bringing forward their unique perspective and contribution to the scientific committee. We kindly request our audience to extend their attention, encouragement, and warm applause as each participant takes the stage.
Principal, Vasant Prabha College of Physiotherapy, Buldhana, and Dr. Sheetal Ghule ma'am, Associate Professor, Community Physiotherapy Department, Maharashtra Institute of Physiotherapy. You can start with first
session. SFPA 002 to share their enlightening research with us. I repeat, code number ELC 25 SFPA 002 to share the enlightening research with us.
Of my paper presentation is empowering the future researchers through a structured publication training program, a pilot educational initiative for physiotherapy interns. Can I have the next slide, please? As we all are aware that in the physiotherapy curriculum, by far we have research methodology, research ethics as a theory subject in third year BPT and 6th semester for the colleges who are assuming the semester pattern. However, practical and formal publication training is not been yet emphasized in physiotherapy curriculum, especially all fraternities in allied health. UG students therefore have less exposure to the research. However, in the final year and internship, they are expected to publish the papers, and but the formal program is not been given to them. So this study is an initiative to identify the research competencies. So coming down to the competencies, when we are giving marks or when we judge them, we do it on the basis of academic excellence, clinical, but not on the research. Consequently, our program outcomes, course outcomes does not much highlight about the research competencies. Next. Therefore, the study had three objectives. First, to identify the research competencies in physiotherapy interns. Second, what are the barriers, what students believe that this could be a barrier to going for the further publication process. And third is to map accordingly the formal publication training program according to the identified research competencies. So, an observational study was conducted to understand what are the students' perspective regarding the publication process. So these are few points that students believe that due to there is lack of formal training, they are holding back to go ahead with publication. There are time constraints. They are already occupied with their clinical posting, academic, extracurricular, co-curricular activities. So time constraint is one thing. There is lack of follow-up. They try to submit the paper, but then once it comes to revision or it rejects, so they don't have a structure or a hierarchy for the follow-up. There is incomplete understanding of the writing and publication process. Many UG students get confused in writing dissertation and publication. They don't understand the difference between dissertation and the manuscript. So that was one thing. And underestimating the importance of a publication. They don't understand that what will happen if my research gets published. So these were few findings of the observational study conducted in my current institute. Guides perspective, I had done an observational study on the UG guides also. So they believe there has to be a formal training implemented in UG students, which will aid and save time of the UG guides also. In implementing the publication credits and scoring, so students will perform better if we score them. So this was one thing. Fostering critical thinking ability through journal clubs, and many projects can be given along with a main project, so that would help him to understand the process. So these were the methods: identification of research competencies, identification of the barriers, and finally implementing the publication training program. So for the identification of the barriers, a questionnaire was designed by considering the opinions of the clinical and senior experts in the field and faculties from the research background. So faculties of research methods were also part of the study. And this was a pilot study done on 10 interns. So these are the research competencies according to their answers to the questionnaire were mapped. So these are the research skill and research competencies. So these are the few comments or the answers given by the students. So as we all can see the graph, 99% of the students believe that there is inadequate research culture. 90% feel that they have limited research exposure. 92 to 90% feel that statistical tool and software they are unaware, and again 90% feel that there is lack of one-to-one training program. So such kind of training program is needed. So this, the publication training program was divided into 4 phases. So these were the phases, altogether 12 weeks. Next slide. It's not going. Yeah. Just prior to that. Yeah. So these are the results. So for assessing a pre-post competency of this program, a questionnaire were designed and descriptive statistics were noted. So according to which, post-program assessment showed improvement in students' self-rated competencies in research method subjects specifically by 32%. Academic writing skill was improved by 28%, and understanding of publication process by 36%. So then out of 10 interned students, 3 students' research articles were published into the peer-reviewed journals, few in Web of Science, and I guess 2 papers in IEEE Explore, which is a Q3 indexed Scopus journal, and 4 are still under submission stage. But these students know how to make a manuscript, how to search a journal accordingly, like that. So this was the key innovation. This was an integration. So this course was added to interns as a value-added course in my current institute, since it's not in the curriculum. So it was given to them as a value-added course. Next slide. So I felt few challenges while conducting this research. First is varying knowledge levels. I understand that a physiotherapist, not all physiotherapists can be researchers. There was understanding of physiotherapy but not of research. So there were varying level of knowledge in students. That was a problem faced by me. Bridging theory and practice. They were knowing types of sampling theoretically, but how to implement into their study and how to put up in the manuscript was a task. Then addressing the diverse disciplines. Few were interested in sports, few were in neuro. So I had to get them all together in one line. So that was the problem. So these are few glimpses. I have a video where a student is performing herself, making a manuscript searching a journal and putting up into the journals. This was a short video of it. I guess I'm over the time. Thank you.
Thank you, Presenter SFPA 002 for that remarkable presentation.
Innovative topic.
Thank you.
That is the need of our, I think, and we all should accept such things at our institutes also. The only one thing that I want to ask is, you said 10 were trained, 3 got published, 4 are under submission process. Before conducting this program, if you have conducted this year, इसके पहले साल का status क्या था? How was the percentage of interns project getting published? So I just want to know, is this program made any difference या ये न करते हुए भी वही status था?
So ma'am, usually in our institute we have interns, 80 to 90 interns, this is the count. And usually, I don't have the percent, but I can tell you the number. So out of 80, 15 projects are by far, I'm talking about academic year 23-24. So out of 80, 15 were published. Now this program is implemented this year, since January. So I just sampled 10. So this was a pilot initiative. So it worked better. Now the upcoming intern will be a major batch. We had an odd batch last year. So this will be a major batch. So they all will be going through the program.
Okay. So maybe after a year or so, we'll come to really know the potential of this program.
Yes, ma'am. And I'm not the only one who's conducting. I have a part of it. I have a team.
Yeah,
so the program is divided into that. Thank you so much.
Thank you, presenter, ELC 25. At 25, SFPA 003, please grace us with your research insights. I repeat, presenter code number. Okay.
So good morning one and all. So the topic for the research is a mixed method pilot randomized control trial on the effect of 1 minute exercise session, that is OMEX, on well-being and work-related musculoskeletal disorders among educators. Now mostly researches are being made on patients. I thought of doing something for the professors, staff members over here. So introduction, workplace musculoskeletal disorders lead to a significant productivity loss and economic impact. Study done in Brazil has said that the prevalence of neck disorders, shoulder disorders, which has been around 45%, 52%, with the lower back being the most affected. The implementation of physical therapists in higher education institution is recommended. So the need for the study, as everyone knows, nearly half of the Indian population does not exercise daily, and the barrier to exercise, everybody says that the time is the most important barrier. Interventions that need to be time effective. Adherence is associated with simplicity of exercise and the time. So therefore we have developed 1 minute exercise session, which is a prevention focused, which is simple and time effective intervention, and the main part of that we try to incorporate in the daily schedule of every educator. And before randomized control trial, we were planning to do this feasibility study. So aim to study the feasibility of OMEX, that is 1 minute exercise session among educators as measured with adherence percentage and randomized percentage of educators. Objectives to measure adherence of OMEX as compared to routine schedule in educators to study the effect of 1 minute exercise session on well-being as measured with JAWS 30, that is Job Affected Wellness Scale, 30 questions, to calculate the effect size and sample size for a full-blown randomized control trial. So feasibility criteria, we had said that if at all there is more than 70% adherence to the OMEX, then we will conclude that it is a feasible study. Methods: design mixed method study, pilot study, allocation method, random allocation, block randomization, concealed through envelopes, blinding, assessors were blinded, participants we included 30 educators out of 41 working in different educational institutes, randomized into 2 groups, which is OMEX group, 1 minute exercise session group, and the other is the control group. Inclusion criteria: age between 25 to 45 years, both genders were included, and academic experience of more than 5 years. Exclusion: history of any orthopedic surgery screened through history, orthopedic condition which hampered participation in the 1 minute exercise session, and those who were exercising regularly. So enrollment out of 41, randomized were 36, allocated were 18 and 18 into each group. Out of that, there were no loss to follow-up. Since the intervention was time effective and simple, we could not find any loss to follow-up. So analyzed 18 in the OMEX group and 18 in the control group. So OMEX group, there were very simple exercises which were to be done at the workplace in only 1 minute. The exercises were very simple: chin tucks, shoulder rolls, shoulder stretches, wrist stretch, wrist roll, leg stretch and calf pumps, and eye relaxation, which were done in sitting position at the workplace where the person was sitting. The other in the position of standing, spine stretch and spine twist. These are just very simple exercises, can be done in 1 minute itself. To facilitate incorporation of this into the daily schedule, we had asked the participants to make alarms on their mobile phones. 2 hourly alarms were set for reminder, and participants were instructed to make a check mark on the time they have completed the OMEX, and if they were unable to do, if they are in a meeting or some place where they are not able to participate, they had to make a cross mark. So daily thrice they were made to do, and total number of sessions were 72. So this is a sample data sheet of the participants. So date when they were doing the exercise, they had to just make a check mark, and when they were not able to do the exercise, they had to make a cross mark. So control group was asked to continue their daily schedule. An awareness session was conducted to tell them the benefits of exercise upon the productivity, and same exercise log sheet was provided to them. Participants were asked to check the time and date at which they performed the exercises. So outcome measures, one was the adherence percentage, total number of sessions completed divided by the number of exercise sessions, which was 72, and the Nordic musculoskeletal questionnaire, and to assess the well-being, job-related affective well-being scale, that is JAWS 30, in which there were 30 questions on 4 domains. So this is a sample job-related affective well-being scale. Since it was a mixed method study, audio was recorded, interviews were taken. There were 4 questions about what is the perception of exercise and well-being, how do you feel about completing the OMEX, what makes you do the exercise and what makes you not do the exercise. Thematic analysis was done. Themes generated were wellness, barriers of OMEX, and facilitators for OMEX. So this was the session which was conducted for the participants. Results, these are the baseline. From the engineering, from physiotherapy and law, 3 institutes we had taken this study. So job-related well-being scale, there were 4 parameters in that, which was HPHA, HPLA, LPHA and LPLA. So there were 4 domains in that: high pleasurable and high arousal, then high pleasurable, low arousal, low pleasurable, high arousal, and low pleasurable, low arousal. So these were the 4 domains of job affective wellness scale. So Nordic musculoskeletal questionnaire. So this is a questionnaire for work-related musculoskeletal disorders for understanding the percentage of population who have this workplace musculoskeletal disorders. So if you see the neck, lower back and the wrist, the OMEX group had the more amount of prevalence, which was less. Of course, the intervention was for 1 month, but there were a lot of psychological factors also involved which led to a positive outcome. So OMEX group, the JAWS scale, which showed 116.6 score out of 150, which is better than the pre. And as compared to the control group, the increase in the score was around 14.2, and for the control group it was around 11.4. So difference between OMEX and control group, it was 6.7 and 1.7. So qualitative analysis was done, which led to some interesting observations. Exercise is absolutely necessary for well-being, just like eating. This was one study for wellness theme. Once it was done, so these are the facilitators and the barriers. And since it was time effective, sample size calculated with the 0.51 effect size and sample size of 168 and 84 in each group. So since it was time effective, it was much better done and incorporated in the daily schedule. Thank you so much. Any questions?
Any question from audience?
The recall bias on the part of the participants, because Nordic relies heavily on the recall period of the contents in the past 7 days.
Yes.
So was there a separate challenge that you had to face for dealing with recall biases of the participants themselves?
Actually, the results which were shown, there were we analyzed for 7 days only, because the other part was for 12 months. So since this is a pilot study, we wanted to see whether the omics can be incorporated in daily schedules of the educators. So since this was not done for 12 months, only the 7 days part was included in the study. So for 7 days, it was easy for the person to recall.
But moving forwards, now that if you're doing a full-scale study, this might become one of the confounders when you do it on a large scale as a 12-month study. So that's where you might want to just check on that and probably accordingly modify.
We'll incorporate for a randomized control trial. Thank you for the suggestion.
All the best.
Because you had some people from physiotherapy background, from law, as well as I think someone else.
Engineering background.
So any sub-analysis with thematic analysis ki physiotherapist ka version kuch thoda different hai, because they are more prone for exercise, or they are more aware because they are medical people belonging to medical thing. Any analysis was done?
Analysis in this study was not done, since it was not the main aim to do the sub-analysis, but this part can be included for the randomized control trial. But there was one observation which was observed in this thematic analysis was physiotherapists were more aware, since you had said that since they were more aware, they were giving responses like it is very much important. Other people were also saying that it is important, but for barriers and facilitators, physiotherapists were much more inclined towards the facilitators and not toward the barriers.
Thank you.
Thank you, President.
Sir, how it will affect that 1 minute exercise session, how it is going to affect the well-being,
yes,
physiological anything effect?
Physiological basis. Yes, actually it's a very good question. But sir, what happens is why we use this 1 minute exercise. Of course, we all know that 1 minute is not going to be sufficient. But this is a prevention-based approach. So it will be followed up for around 12 months or maybe 15 months. It will be a long duration study. So this was only to understand whether the omics can be incorporated in daily schedule or not. But of course, as you are saying that how 1 minute is going to affect the well-being. But the next part of this study will be a very 12-month study, which will actually test whether this is going to affect the well-being or not.
Thank you, sir.
Thank you, sir. Thank you.
Sir,
72 sessions. Yes.
Exercise. And how many exercises exactly you were giving?
Ma'am, exercise were in standing, there were 2 exercises, and in sitting position, there were 9 exercises.
Yeah. Sir, so you have given any gap in between the exercises, or continuously 1 minute you have taken?
Continuously, they have to do, just ma'am, since you have asked this question,
Yeah.
they are very simple exercises to perform at the workplace, like, shoulder rolls, wrist stretch, so they can be completed in 1 minute itself.
Yeah, so how many, repetition you
Yes,
had
repetitions were given in that. Since we are short of time, it was difficult to explain. There were around 5 repetitions, and for stretches, there were around 5 seconds of stretch.
So every exercises you have given for a 5 repetition?
Yes. And for stretches, there were 5 seconds of stretch.
Okay.
Yes.
And what about some might have completed early, some might have completed late, right? 5 exercises within, how many exercises you have given?
Yes.
Was that, the patient was able to complete that within a minute, in 1 minute all?
Yes, since the aim of this study was to make it as time effective as possible, they were to do in the workplace. So let's suppose some teachers working on a computer, and they were made to have that alarms. So once that 10:30 alarm sounded on the mobile phone, they have to do it on that workplace itself. They have to roll their shoulders, they have to make the wrist stretch, they have to make the calf pumps. It will be over in maximum 60 or 70 seconds. So once they do that, they'll continue their work. So main aim was to incorporate in daily schedule, since time is a very important factor where we are not able to do the exercises. So since it is so short, it was easy to incorporate, so they could do it in the workplace, and therefore this is like a prevention focused approach. And maybe in the next randomized control trial, we'll see the long-term effect of that.
Okay, okay, good, nice study, sir.
Yes.
Thank you, presenter, ELC25 SFPA 003 for delivering such a thought-provoking and insightful presentation.
Thank you so much for the questions. Thank you, ma'am.
SFPA 005, the stage is yours to present your findings.
Actually, I want to thank Khatri sir and Singarvelan sir, because they are our teachers. The way of presentation has been taught by sir. So thank you so much, sir.
Fraternity for the conference. I'm going to be talking about the ability of the face mask to affect the ability to do exercises during the pre-COVID-19 time. And I'm going back when we had just started off using face masks for prevention during the COVID-19, and people tend to continue that as a public health policy moving forwards. So the question that arose was, do face masks affect exercise performance, and evidence from cardiopulmonary and perceptual measures? The slide changer, please. So put it in the context, the COVID-19 has brought about a lot of public health challenges in terms of addressing the ability to do exercises, both at workplaces and otherwise. And that's where we thought, let us try and study whether face masks have an ability to change the way we exercise or affect the way we exercise in both the therapeutic parts as well as the non-therapeutic evidences. So our study design employed a cross-sectional observation. We didn't want it to put them into an intervention to begin with. So participant selection made about 50 healthy adults who were aged between 18 to 30 years and who were first screened with the Rockport fitness test. That was a test meant for assessing the aerobic performances of non-physically active individuals. Exercise protocol was used as a means to understand whether they will be able to perform the same set of running treadmill exercise with and without a face mask, just to know what are their cognitive, perceptual and cardiopulmonary affections in the long run. We also did a data collection to improve upon their aerobic endurances by studying predictable equations of VO2 max. We also looked into the heart rate recoveries at the start of the exercise, at second minute and at the third minute of exercises. And finally, a statistical analysis using Pearson's correlation coefficient and a Mann-Whitney, looking into the probability samples at the start. These were the key physiological measures that we looked into, starting with the predicted VO2 max that was specifically meant for catering to non-physically active individuals, a heart rate recovery that was measured at the start, at the end of 2 minutes, and at the end of 3 minutes post-exercises. This was a reflection of the way the participants were able to perform a modified Bruce protocol with and without a face mask. And we also took a rate of perceived exertion as a means to understand whether are they able to continue doing that set of exercises with the mask on. The highlights on the table here shows the ranges by which we used to select the participants as a part of our study samples. What we could find out from our key findings was there was a strong correlation between the predicted VO2 max found between oxygen consumption and without face mask during walking. One of the key findings that people without a mask were able to perform a lot better on the Bruce as compared to ones with the mask on. The heart rate recovery at the end of 2 minutes showed 0.7% of an association that also helps us understand that at the end of 2 minutes, people were starting to feel a little discomfort with the mask on. And at the end of 3 minutes was the strongest prediction in terms of whether would they be able to continue the exercise beyond a 3-minute period or not, even though the modified Bruce protocol made them do it for 12 minutes, but the physiological changes started coming to an at the end of 3 minutes of exercise itself. What we could not rather find out in terms of VO2 max, which was the predictive aerobic endurance capacity of an individual, was in terms of a strong association for with and without face masks, and the mean value ranged between 76.8 milliliters per kg per minute with the mask on and 81.02 milliliters per kg per minute without the face mask. So what are we trying to imbibe and understand upon is whether putting anything on the mouth affects your capacity of the lungs to inflate and deflate or not. And the minimal difference suggests that there could be a face mask that is actually disrupting the breathing pattern itself. But when we do exercises on a logger sample base, that means beyond a 3-minute or a 4-minute exercise, the minimal changes are to be seen. Heart rate recovery patterns has shown quite a strong indicator in terms of whether the individuals would be able to continue and sustain the efforts or not. merely starting up an exercise was still good, but as they started exercising more, they start spending more on the exercises, the association had just dropped down a lot. So immediately post-exercise, as the body starts their own habituation processes, at the end of first minute, whereas the initial vagal sympathetic activity starts to set in, at the end of 2 minutes, the strongest association because the recovery has now stabilized, and at the end of 3 minutes is the strongest association indicating a constant recovery patterns. That means as you start exercising more with the face mask on, your ability to adjust to the changing environments is increased considerably enough. The rate of perceived exertion surprisingly has not had any effect in terms of the relationship between either a heart rate recovery or even for that matter the condition as a mask or without a mask. RPE with mask was shown to be 11.28, without a mask was 11.24 with a weak association of 0.5 itself. Participants had to stop due to muscle fatigue and the rate for respiratory distress was setting in. The discomfort experienced by the general set of populations is primarily due to lack of adaptation because we had targeted the individuals who are not otherwise physically active. So in a way, people who are not used to doing exercises but are still using face mask during their exercise sessions are the most prone to develop respiratory distress as they start exercising more. And that's a very small but a very important finding that we could gather, that associations between a mask and the respiratory distress was found to be on a higher side, and thereby the perceptual measures can be a long-term phenomenon and an investment into research as well. We also try to understand whether the type of the face mask has any effect. So on a statistical note, we could not, but when we reported the findings and observations of our participants, we found that cloth face masks were reusable, commercially available. They reported moderate comfort during the exercises. Naturally, N95 participants were the ones who were able to sustain that activity far longer. And there were all masks provide protection, but N95 respiratory distress was the last. So the rate of perceived exertion with the people using a respirator mask was found to be better as compared to a cloth mask or even a surgical mask for that matter. So masks are safe for exercise. A lot of our participants still come back asking whether is it safe enough to start using face masks on a regular basis when they exercise in their fitness routines. So the major key takeaways are there are no adverse physiological effects to begin with. There's only a slight alterations, but I would rather say that slight alterations due to their physical activity status rather than the mask itself. There's no significant change in the discomfort levels, rather they found it better as they started exercising for a longer time. And the perceived discomfort is largely psychological and adaptation related rather than their own ability of the lungs to inflate and deflate depending on the requirements of the exercise itself. That's all for so. Thank you so much.
Any question from audience?
Sir, is there any relation between maximum oxygen consumption and ventilation?
Medical oxygen.
Maximum oxygen consumption and ventilation. Means how much air you are taking. Is a relation between maximum oxygen consumption, VO2 max and ventilation?
Well, as a part of our study, we did not do that. But when I look at the participants, like if you are coming from a physically active background, somebody who has a very stable structure when it comes to exercises, the evidences talk about having a better resilience to the exercises. The ability to do exercises will be better as compared to the ones who are not active in the long run. That's one. Secondly, when we talk about exercises on a longer run, there is certain sense as they will start adapting to a stimulus. Once you start adapting to a stimulus, naturally the acceptance on the part of the mental social well-being of an individual is seen better. But I would not say that because I have not done that study. But I would rather recommend to study that aspect into an exercise plan also, because that's where the adherence rate of exercises can be evaluated.
How you will, you have calculated VO2 max?
Yes, we did.
With formula, sir?
Yes, we used a predictive equation to do that. Because the individuals were not coming from an exercising background. So we used a predictive equation that was mainly meant for a non-physically active individual.
Good afternoon, sir. Yeah. Which was a good study. Was the target heart rate with mask and without mask? That was my question.
So when we looked into the age predicted maximum heart rate, we could not find any difference. And that's the reason we did not include it in our statistical part as well. But having said that, I believe age predicted heart rate might not be a better indicator of a target heart rate because we have not done a respiratory analysis. We have just used a predictive equation to see the feasibility aspects of it. But I'm sure when we move further with our understanding of respiratory distress with the face mask on, that point can definitely be accepted, sir.
Okay. Thank you, sir.
Thank you, sir.
Innovative and compelling study with us. For now, second session, our judges are Radha Bhattar ma'am and Vijay Pandita. SFPA 007, kindly come forward to present your research. 007.
Good afternoon all. The study of my title is Availability, Usage and Factor Affecting the Usage of Electrophysical Agents by the Physiotherapist. So basically what I'm trying to do is I'm trying to find out what are the modalities available in the clinics and what is the usage and what are the factors or how they are making a clinical decision. Next slide, please. So this is my abstract. Okay, coming to the need of the study. So the basic idea is there could be variation in the teaching methods of electrotherapy which could affect the clinical decision making of the modalities. So my study is interested to know that. Second thing is we are the students using the evidence-based selection. And finally, where is our professional competency and the quality of care? So my first aim of study is to determine the electrophysical agents available and their usage by the physiotherapist. So my objectives are to identify the modalities in use, to estimate the frequency of use, and to determine what are the factors that are influencing the selection. Coming to the methodology, it's a simple observational cross-sectional study which included 120 physiotherapists who have greater than 1 year of experience. And my sampling method was convenience, and we made a self-made validated questionnaire which was validated by 3 subject experts, and we have analyzed it using Excel and SPSS. So the questionnaire included 3 parts. The first part was demographics, which included 10 questions. The second part was the availability and usage of the electrophysical agents at their setup. And the third part of questionnaire was factors that are affecting the selection, and it had 16 questions. So the results show that we had a response rate of 80% in whom we approached. And we see that the practice area, the major area is the MSK specialty, which is followed by the general, that is mostly they may be UG, and we have a remaining the community, PEDS and sports and general. And if you see the distribution of their qualification, a major or BPT 52% and MPT are 46% and 2% were the PhDs. So coming to the availability, so we have included 22 modalities. ultrasound, shortwave diathermy, IFT, Russian currents, iontophoresis, TENS, direct current, and so on. And we had few rarer equipment like magnetotherapy, TECAR therapy, which are also included. Coming to the availability, that is most available instrument, that is ultrasound, IFT, and TENS. These three modalities were almost available in all the clinics. And coming to the usage pattern showed a different thing. That is, the most commonly used modality was the thermal agents. That is hot pack and cold pack. And ultrasound, the next was ultrasound and IFT. So coming to the factors that affected the selection, so these were the questions, and the first one was the least which was considered was the preference of the patient and the reference, and the most influential factor was the availability of the modality, the past experience with it, and the evidence. So our curriculum is guiding them correctly. Coming to the discussion, so my study aligns with the three other authors, Abitol, Springer, and Shah and Faro. And the ultrasound, IFT, and TENS were the most available modalities across the India. And thermal agents were the still preferred for pain and inflammation. And there is a gradual decline in the modalities like SWD, IR lamps, and UVR lamps. Then there were newer equipment which were TECAR therapy, magnetotherapy, microcurrents, etc. They showed very limited availability, maybe because of the cost. And evidence-based practice and the clinical confidence significantly influences, as said by Watson. So this was considered by all the physiotherapists, which was one of the good findings. The availability and the clinical condition remain the strongest factor. So still, even if they know the evidence, still they were considering the availability of the modality also. So the patient preference and physician instructions had minimal impact. The education and training shape the usage pattern. So this again tells that our curriculum is going correctly, and shared decision making and patient involvement should be strengthened because that was not considered. And the findings emphasize for the need of continual professional development for updating the institutional resources. So my conclusion is the EPS still remain a widely available, and it is inseparable from the field of physiotherapy. And the most frequent used modalities were, as I said again, ultrasound, IFT, TENS, then thermal agents. The clinical decision was depending upon condition, availability, and evidence. And an update in the curriculum promotes the evidence-based usage. So coming to the clinical implications, we need to ensure up-to-date equipment and evidence alignment. The review less used modality and find out the reason for that, and promote the evidence-based practice and training programs, and develop decision-making frameworks for the physiotherapist. We don't have a clinical practice guidelines in electrotherapy. Maybe there is a strong need for that. Next slide, please. So the limitations are, there was no subgroup analysis based on their faculty or electives. Future studies can track the EPA agents based on the time. Findings can guide the new graduates, the clinical decision making. Thank you.
Good afternoon, sir.
Good afternoon.
So, like the evidence says, majority of the like electronic devices are not used because of the contraindication disadvantages. Like I think IFT, TENS, and ultrasound have less contraindication and disadvantages comparing to lasers and IRR therapies. So it should be included on the evidence. If
Sorry, I didn't understand your question.
Like majority of the clinical devices or electro devices are not used due to their contraindications.
There is some echoing. I am not able to understand a part of your question.
Let's say you have mentioned that majority of the devices are not used due to their expenses, like they are cost. But I think it are not used due to their contraindication and disadvantages as more.
Yes, you are right. That's what I was trying to tell you. We have to investigate, assess and find out, do a study and find out why the clinical use of those modalities has declined. As you said, there could be contraindications, but I'll tell you, when it comes to less used modality like SWD, so everybody is afraid that it produces radiation. But I'll tell you, your mobile phone also produces radiation and it is on our body 24/7. And the radiation in the treatment duration of 10 minutes to 20 minutes, I don't think will be a big factor.
So if any evidence that can say that how a contraindication can be reduced and disadvantages can be reduced, it could be more beneficial.
As of my knowledge, we don't have any evidence which states that these are the risk factors for this modality, it can produce some condition.
The use of TENS is more. Does that mean that indirectly your research shows that our practice is also like medical field, try to minimize the symptoms? Because TENS is one of the easy available modality with, as you said, list contraindications. And then that means, are we as a physiotherapist also giving priority to minimize the symptoms rather than working at the underlying pathology?
Thank you for the question, sir. So, basically, what I understood is, sir is asking me whether we should be treating the symptoms. Okay. So, basically, sir, as you already know, we use electrotherapy mainly for pain, reducing inflammation, and one of the main reason for which we should include electrotherapy is tissue healing. If we could accelerate the tissue healing, just not concentrating on the symptom only, symptom has the first priority, but the second priority should be healing. If you could reduce the suffering days from the condition, I think that will be a great achievement. Hope I have answered your question, sir.
Actually, instead of question, it was like opinion. Like, are we going in this favor that we want to minimize more of symptoms rather than working at pathology? Because TENS is helping you to alleviate the symptoms. And another suggestion is, just take it as a suggestion. Shorter diathermy is not a radiation. Shorter diathermy is electromagnetic waves. And electromagnetic waves, I'm sure you know that in medical field, when we say the radiation, it's like X-rays and other things, and different wavelengths are there. It's basically electromagnetic waves. Electromagnetic waves, as you said, it's part of our life, right? From mobile, microwaves, everywhere, electromagnetic waves are there. It's just, what do you say? They're not harmful. But as he asked, one thing, like, we don't have anything to do with the contraindications. What it is there, it is going to be there. We are not going to reduce it or increase it. So now, then, where is the issue? Issue is very simple. I'm sure these international people, yesterday he said, like, Western people, sometimes they come out with something like, there's no evidence, and then we do that practice upside down. Someone landed up publishing one paper that you apply shorter diathermy and it can produce osteoporosis. People have actually almost, put up the shorter diathermy. No one looks into the quality of that research, what it was there. Should we really change our practice? But no. Research says like this, and that's it. But on the contrary, as you said, the evidence start right from your personal opinion, or just one single patient also. You apply shorter diathermy, immediately, during treatment, sometimes the patient sleeps also. So there's a sedative effect, there's a calming down effect. Forget about what the research says, what the evidence says. When you are seeing that patient is feeling better, why not to use it? So sometimes the practice depends on how the clinician thinks also. Yes, and I do agree, it depends on available modalities also. If in a clinic you just got 3 modalities, then definitely you're going to choose out of 3 only. If you got 5, you're going to choose it out of 5.
Very true, sir. Thank you, sir.
Thank you, sir, for that illuminating presentation. Number ELC 25 SFPA 008, please share your research findings with us.
Everyone.
My topic today is a case presentation. So integrated biofeedback and electrotherapy for pelvic floor rehabilitation, a case of wall prolapse with urinary incontinence. So introduction, the pelvic floor disorders encompasses urinary incontinence and vaginal wall prolapse affecting the bladder control and pelvic organ support. So prevalence for this is 40 to 50% of women post-hysterectomy experiences pelvic floor disorders symptoms where you can have stress incontinence, urge incontinence or mixed incontinence. So the risk factors are the surgical disruption of the pelvic ligaments, hormonal changes and the aging weakening of the pelvic floor muscles. So the critical gap over here can be the hysterectomy is also known risk for this. So compounding the effects of the subsequent lumbar spine surgeries, that is the L4, L5 laminectomy is often overlooked in the clinical guidelines. The neurological impairment is like the L4, L5 procedures can disrupt the peripheral nerve functions, potentially impairing the S2, S4 neurological pathway which are vital for optional pelvic floor muscle activation and support. So traditionally non-invasive physical therapy protocol often designed for the isolated pelvic floor disorders may require modification for the patients presenting with the dual risk profile and acute neurological changes. So here methodology, the female was 48 years old with from Indore, housemaker, and she had gravida 3, parity 3, living 3, no abortions. There was no any comorbidities suffering from. She had an hysterectomy 8 years ago. Leaking of the present complaints were leaking of urine, sometimes some part of something coming out of the vagina, walking difficulties as she was operated for the laminectomy. So diagnosis for lumbar laminectomy, L4, L5 with urinary incontinence and wall prolapse. Pre-operative status, she had just a lower limb weakness or pain in the low back region also. So surgery was performed on 4th of June for laminectomy, after which she had the problems facing for balance and walking difficulty and urinary incontinence and wall prolapse. So I had given IFT for this, where IFT is working for your neurological, can be it neurological activation of the muscle. So this was the present, this placements of the were on the lower abdominal and in the middle of the thigh. So for biofeedback, I had used perinometer, where the probe was inserted and the meter was given in her hand so that she could see the readings of her contractions on the meter. So before, this is the wall prolapse and this is after 6 months of the treatment. So we had focused more on the Kegels exercises with progressive training, where we had used the perinometer. The 2 mm Hg was the pressure increased on it, and she had to feel the contractions over there. The speed and quick release were also given. So 5 seconds hold for 10 repetitions it was given, and it was increased for 10 seconds hold. So the pre-treatment, the pelvic floor muscle, where it was on grade 0, which has increased to grade 3 out of 5, and significant return of the neuromuscular control was there. Severe mixed urinary incontinence had come to mild, and marked reduction in the frequency, where she had where she was using pads like diapers, which was 4 to 5 per day, has decreased to 1 diaper per day. And in wall prolapse, where it was prominent prolapse which was seen, had been reduced. There was poor core stability also, which improved it, and her quality of life is also increased. So the patient had severe loss of the muscle control confirmed by the grade 0 perinometry. IFT was started to re-establish the neuromuscular activation, where the feedback was given with the patient visualizing her pelvic floor strength, unable to visualize the contractions. So we had given her perinometer. Finally, we started with the progressive Kegels exercise to ensure the muscle was strong, and had to stay in power. So it proves that comprehensive physiotherapy program is a highly effective first-line strategy for severe pelvic floor problems, potentially helping patients to avoid the need for additional surgeries like bladder lifts or any prolapse repair. Thank you.
Any questions from audience? Thank you, ma'am, for your.
Thank you.
Next presenter. Yes, I repeat, presenter code number ELC 25 PhD SP 041. The floor is yours. Yes, ma'am. Sorry.
Good afternoon.
Sorry, ma'am. In flow.
Good afternoon, everyone. Am I audible? Yes, am I audible? Okay, thank you, sir. Well, today morning we have had very good discussion about the electrodiagnosis and physiotherapy, and I hope my talk also keeps you all engaged and add some more dimensions and trigger some more discussion at the end of this topic. Now, the title of my study is Clinical Practice Guidelines in Facial Nerve Electrodiagnosis. Through this study, I wish to propose guidelines for facial nerve electrodiagnosis. This is just a preliminary draft based on evidence from the literature review, and this will be further subjected to more rigorous methods such as consensus building exercise through Delphi process. So, well, again, many speakers have already highlighted the need for this topic. Well, I would like to add that facial nerve affection having more cosmetic, psychological impact on the person if no recovery. So, it is very important for us to diagnose and to assess its severity very early so that prompt management can be decided upon. So, this is just a prevalence of how common the facial nerve palsy is. However, again, it is noticed that though it is an established technique, many clinicians don't use electrodiagnosis of facial nerve in their practice. Well, these are some of the keywords I will be repeatedly using in my presentation. The aim of this study, as I said, I wish to propose clinical practice guidelines, basically to know what is the diagnostic prognostic utility, what are the parameters of significance, what are the clinical correlates of electrodiagnosis, and what is its role in surgical exploration and management. I also try to search if there are already existing recommendations or CPGs related to this facial nerve diagnosis. So, there was an extensive literature search I conducted using electronic databases. I tried to search electrodiagnosis in general as well as for facial nerve palsy. I came across varied types of studies in which cross-sectional studies were predominantly found. These are some of the studies which I came across. Well, these are the key themes, as I already mentioned, which emerged after the literature search. Well, in the literature, it is seen that clinical measures dominate the assessment of facial nerve palsy, whereas electrodiagnosis is less used regularly. SD curve is often performed by a physiotherapist, whereas other electrodiagnostic studies are performed by medicine experts such as ENT specialists, head neck surgeons, or neurologists. Well, the purpose and scope of electrodiagnosis in peripheral nerve injuries is well known by us. This is a historical evolution of different electrodiagnostic tests which evolved over time. Duchenne was the first who came with the electrostimulation as a prognostic tool. Later it was the blink reflex which became the first electrodiagnostic test in facial nerve palsy. Then added was a nerve excitability test, maximal stimulation test, and here we come with the contemporary techniques which are electroneurography, electromyography, motor nerve conduction studies, and also SD curve. When we look at the overview, some of the tests are subjective and are can have inter-rater variability as the bias. Needle EMG and ENOG adds to more quantitative methods. I came across studies which discuss the role of various electrodiagnostic procedures, and I did comparative analysis of them. Now here in this study, it's a good review which talks about EMG, NCS, SD curve and some other techniques as in, with comparison to each other. Most of the studies have highlighted electroneurography, NCS, EMG as better indicators of degree and severity of denervation. EMG is an important tool to analyze or assess denervation and regeneration of the nerve later in the course. Again, this study highlights the quantitative assessment's importance, and also to add to it, we can also see there is something called as muscle specificity, in which certain muscles show a different pattern of electrical responses as compared to other muscles. Okay, so because of time constraint, I am going a bit fast. However, also talking about the timing of the electrodiagnosis, some of the studies have highlighted the importance of early assessment as early as 7 to 10 days. Now this is added dimension of electrodiagnosis. Routinely we don't do it, but this is topodiagnostic assessment using electrical means to reveal the site of lesion. So some of the tests are useful in predicting the, in assessing or diagnosing the site as well. Through the literature so far, we came across a differential significance which highlights that not a single test is diagnostic in itself, and it also highlights the need for having integration of multiple electrophysiological tests in predicting better outcomes. Through decision tree algorithm, these 5 key recovery factors were assessed. Now I have mentioned other because they are not in use currently. So strength duration curve seems to be outdated now from our practice, which is largely superseded by EMG and other diagnostic measures. Again, there is a new upcoming tool like transcranial magnetic stimulation and antidromic evoked potential, but it is still at preliminary research level. There are definitely merits of SD curve over other diagnostic tools. Well, I am coming to this important point of optimal timing. When we discuss the timing, it is very important that we need to know the pathological and physiological nerve injury and recovery. Definite patterns of electrical events exist to this, and we should know that excitability is retained for first 48 to 72 hours, later it is lost. So the final window, though it is 21, there is evidence that early assessment also gives very valuable information. Optimal timing of EDX study depends upon the type of lesion. It will vary with neuropraxia, axonotmesis, neurotmesis. It also depends on which clinical question we are asking. Are we supposed to localize only, or to know complete versus incomplete? Or we need to know more information, need to gather more information related to re-innervation. So this is again differential sensitivity of different electrodiagnostic tools to denervation and re-innervation, and thereby they predict different severity outcomes. Okay, so there are some procedural considerations in which I would like to highlight the importance of definitely equipment, safety, calibration, multi-channel recording is also required. Now this is another important point which highlights the need to have at least one muscle from every branch of facial nerve tested. Previous researchers have highlighted the anatomical orientation of the nerve, and it does show differential vulnerability of different nerve fibers in the course of their intratemporal and extratemporal course. So it is very important that we test each major area by mapping different muscles supplied by every different nerve branch. So this is the importance of muscle mapping in facial nerve palsy. Parameters, well, some of them are just visually estimated, whereas others are recorded and measured. So this highlights the need for having more quantitative measures like interference pattern. Yes, so just coming to the last slide probably. Yes, so some time back, some speaker mentioned the need for having better documentation. This is a form I tried to create for strength duration curve, highlighting how technical procedural aspects should be mentioned as well as the timing of our assessment. Okay, so just I'll show you the draft I have created out of all these literature studies. Okay, so I try to propose the draft with the following, with these key themes as patient selection, optimum timing, selection of techniques, selection of muscles, equipment and procedural considerations, and how do we interpret and document. So these are some of the clinical practice guidelines statements which I am making from the based on the literature review as to when the electrodiagnosis should be done. Some of the previous recommendations say it should be reserved for some unrecovering cases. However, I emphasize that all patients presenting with facial nerve palsy, irrespective of etiology or recovery status, should be subjected to electrodiagnostic testing. And again, for every statement I have provided the rationale. So some 17 statements I am making based on that, and just to add that we can also use AI predictive analytics to create algorithms to support clinical decisions. Okay, so the content was more, I tried to shed some light on every aspect of it. However, if any doubts, I would like to elaborate the content I am showing. Thank you everyone.
Any question from judges? Any questions from audience?
Hello, ma'am. So my question, ma'am, is the points which you have mentioned in the documentation of the data recording form, is it subjected to any specific validity or reliability testing, or this is just a finding on basis of the evidences which you have fetched?
Yes, you meant to say did I have
you
created?
done any,
Yes, it is not existing for any of the tools.
That's okay, ma'am. It's not existing, but which you have made it with respect to the evidences available. Have you checked reliability, validity?
There was one study which is tried to create such guidelines for documentation. It has used many other tools together in the same documentation format. So I have tried to create one separate for strength duration curve here. But I have referred to that document in which the muscle and the nerve pair which is studied, the side. Also, I would like to add that we should ideally check both the sides in phase, even if one side only is affected, and do comparison. There are quantitative criteria for knowing that is it affected or no based on bilateral comparison. So that point also I have added in the documentation form.
Ma'am, have you tried to implement this documentation form in any which of your patients?
Madam, I have been using SDC very rigorously in my clinical practice, and I try to, actually this form came from that practice.
Okay.
And now definitely I will reinforce again it in my practice.
Okay.
Yes. Thank you so much.
Thank you, ma'am.
Ma'am, just a suggestion, because your study is still a proposal.
Yes, sir.
Any CPG guidelines have to be developed from a pre-development phase to evidence synthesis to post-development phase and validation.
Yes, sir.
So if it's a proposal, I would recommend that you break down your proposals into these 4 parts and try to justify why these guidelines are contextualized to an Indian setting. The reason being, most of the CPGs that we are following in the practice are developed in the West, and we are now, practicing in our country, which is resource constraint, and there are so many socio-cultural factors that come into the practice in the first place. So, if it's a proposal, I would recommend कि आप proposal को 4 से 5 phases में divide करके हर एक phase को patients में test कीजिए, तो your study becomes more valuable and precious in the long run.
Yes, sir.
Yeah.
I agree. Sir, I have mentioned that as a future scope of this draft, that this is just generating hypothesis, and from the literature alone, it needs backup from clinical research and definitely experts consensus building exercise through more rigorous process such as Delphi process, and further definitely validation on patients also. Yes. Thank you very much.
Ma'am, you said various diagnostic tests, right? From there,
various diagnostic
test you have said, no, SD curve and all. So you said like SD curve is more applicable. So is it so like we can apply that to the more patient, means like that is the main test which we have to do?
We do have a repertoire of tools available to us, even as physiotherapists. It is not only SDC, EMG, NCV also we do. ENOG is not very technically demanding procedure. We can also implement that. Currently it is in the domain of ENT specialist, but we have a repertoire of tool in which, yes, definitely SDC stands out because it is cost effective tool. It is definitely low cost, not in terms of money alone, but also time and efforts, and regularly more frequently we can do SD curve plotting for our patients. And it is also seen, not only that factor, but it is also seen that it is more informative in the early stages of denervation, where EMG takes at least 10 to 14 days time to detect changes in the facial muscles. SDC can detect the change as early as 72 hours, within 72 hours. So I think there is no harm in using SDC curve definitely in our practice, not to definitely lose it from our domain. And other tools are there, but they do have some limitations also. So whichever tool we use, we have to use it with proper justification, respecting the timing also of the acute or chronic stage of nerve recovery.
Thank you. Nice study.
Thank you so much.
Thank you, ma'am, for delivering such a comprehensive study. Next presenter, code number ELC25 PhD SP 049. Kindly come forward and enlighten us with your research.
I would like to thank Khatri sir for giving this opportunity to present our study and creating this platform for us. My topic for presentation is effect of transcranial direct current stimulation, that is TDCS, on spasticity of lower limb, balance, gait parameters and quality of life in stroke patients. Need of the study. Worldwide, almost 4.8 million people survived with stroke and 1.1 million experience the long-term disabilities. Around 80% have an impaired balance and postural control problems, and 38% remains non-ambulatory after even the 6 months, which is mentioned by the Global Stroke Fact Sheet 2022. Can I have a mic, please? Thank you. So the recovery basically depends more on the cortical reorganization, sticking to the session today about related to the electrotherapy. So more I'll be concentrating on the work of the electrotherapy, including the TDCS. So the TDCS is a modern, portable, non-invasive neuromodulatory method which applies a steady, low-frequency current to the brain using electrode, and has been designed to aid individuals suffering from mental illnesses or brain traumas. Aim of the study was to study the effect of transcranial direct current stimulation on spasticity of lower limb, balance, gait parameter and quality of life in stroke patients. The objective was to investigate the individual effect of anodal, cathedral, bicephalic and sham TDCS on spasticity of lower limb, balance, gait parameter and quality of life, and comparing at last the effect of all the 4 stimulations which are used. Research methodology. After submitting the topic to the for the University Ethics Committee, and a trial registry was done related to the topic. And the study design was experimental study. It is a comparative study. The target population was stroke patients. After calculating the sample size, it was taken as 80. Sorry. The inclusion criteria consisted of patients which were diagnosed with one-time stroke, considering the definition for stroke according to given by the WHO. Both genders were taken. MMSE was taken more than or equal to 23, and lower limb spasticity was measured using the modified Ashworth scale with grade 1 to grade 2, and BBS score was 21 to 40. Exclusion criteria were the patients having impaired skin sensation over the placement of electrodes consisting of maybe eczemas or rashes or blisters. Patients operated or having implants, metallic implants, stimulators in the brain were excluded. Patients who had undergone any sort of craniotomy were also, or neoplasm also were excluded. And functional limitations, patients having with the musculoskeletal injuries like fractures or dislocations, sprains were with the lower limb were also excluded, and patients with any epileptic disorders were excluded. The materials used were pen, chair, electrode, TDCS machine, stopwatch, measuring tape, and ultrasonic gel. The procedure, total 85 patients were chosen, number of patient volunteers were 80, and the dropouts were 5, and group A, B, C, and D had 20 patients in common, and TDCS treatment was given 3 sessions, that is for 20 minutes for 3 days per week for 3 weeks, that was total 9 sessions. So pre and post assessments were done for all of these patients considering the cortical stimulation, that is before the stimulation. MMSE was measured for the cognition, modified Ashworth scale for measuring of spasticity, SSQL for the quality of life, BBS for balance, and the Neurocom balance master was used for the assessment for the balance and gait parameters. And the groups which included were anodal, cathodal, bicephalic, and sham TDCS. The outcome measures were for the balance and gait assessment, it was done by using the balance master, the modified Ashworth scale, BBS, MMSE, and SSQL. This is the assessment on the balance master, assessing the patient for the squatting percentage. Sit to stand, walk across, and step over. This electrode placement was considered the EEG, that is 10-20 system for the TDCS. The electrodes were placed for the anodal, cathodal, bicephalic, and sham TDCS. The intervention in this procedure, subjects were seated and procedure was explained to them. The electrodes was placed according to the EEG, that is 10-20 system. Patients were informed about mild tingling, and slowly gradually the current was increased to 2 milliampere. TDCS was applied for 20 minutes, and lower limb functional exercises were carried with the TDCS. These were the lower limb exercise which the patient did with the TDCS applied to them. The termination criteria was considered in this. The stimulation TDCS would be stopped if there were any development of any adverse effects. Statistical analysis, the data was analyzed using the statistical package of SPSS 2026. Descriptive statistics was done. The normative of the data was considered by using the Kolmogorov-Smirnov test, and the inferential statistic was done out to find the difference within a group using the one-way ANOVA followed by Bunfer and post-hoc test. All groups were homogenized in baseline after applying one-way ANOVA for pre-test and the post-test analysis. Within group analysis was done with pair t-test, between was with the independent t-test. So with the modified Ashworth scale, it showed that the sham group, that is the fourth group, group D, they did not have any patient with grade 2 spasticity. So there was not much difference in reduction of this spasticity. BBS scored showed that it was statistically significant in all the groups. With SSQL, anodal TDCS showed statistically it was quite better as compared to the other type of stimulation. With MMSE also, the anodal TDCS showed a statistical significant difference as compared to other type of stimulation. Again with the balance master, considering the weight bearing, here also the anodal TDCS was far better as compared to other. And with weight bearing and squatting test also, the anodal TDCS showed more better result as compared to the other type of stimulation. For sit to stand also, the anodal TDCS showed statistically more better as compared to other type of modalities. Discussion, this study explores the transcranial direct current stimulation as an adjunct to the stroke rehabilitation. With growing knowledge of post-stroke neuroplasticity, TDCS offers a non-invasive way to modulate cortical excitability and aid recovery with emphasizing integration with conventional therapy. So comparing modified Ashworth scale with the cortical stimulation, it showed that spasticity, that by modulating the cortical excitability and enhancing neuroplasticity, TDCS promotes reorganizing of motor pathways and rehabilitation of the motor cortex, which was seen in all the groups. comparing the SSQL, that is the quality of life in patients, the quality of life in stroke survivor is often reduced due to the spasticity. So the SSQL showed, in this study, it showed that anodal TDCS had a better effect as compared to other type of stimulation. So evidence shows that transcranial direct stimulation is a safe, effective method that enhances the brain plasticity and reduces the depression. It showed a better effect with cortical stimulation on the MMSE, that is the cognition, that is the evidence also showed that non-invasive brain stimulation promotes a synaptic neuroplasticity, aids the cognitive recovery in stroke patients. So BBS also had a better effect. Conclusion, the excitatory TDCS showed more improvement in BBS score, MMSE, SSQL in enhancing the postural stability, cognition and quality of life. Strength of the study, TDCS is emerging as an effective and versatile treatment tool to prime the neuromotor system prior to or during rehabilitation. It's a neuromodulated technique widely studied because of its portability and decreased safety risk, easy to be used compared to other neuromodulated techniques. So limitations were outcome measure assessments was not blinded due to the feasibility issue. Progression of exercise intervention among individuals was variable in nature and follow-up measurements were not done after 3 weeks. For the scope of the study, it could be studied with the functional connectivity, that is using the functional MRI, the effect of TDCS could be studied further. Variables which could be studied with TDS would be the brain injury, the subject's age, pre-lesional neurological status, the interaction of TDCS effects with cerebral reorganization enabling the functional recovery in various conditions would be further studies. This would be the further recommendations. These are my references. Thank you.
Thank you, ma'am, for brilliant presentation. Any questions from judges? Any more questions from audience? Thank you, ma'am.
Just two things. We have taken modified Ashworth scale as an outcome measure.
Yes.
What is your say? Is it that sensitive to pick up the change in this short duration, or H reflex or other thing could be a better outcome measure, to a sensitive one to pick the change for spasticity?
H reflex would have been better because considering the lower limb, but again, it is like feasibility of getting the patient to the department again for like from the ward, because for TDCS it was for me that it is a small machine, so it was portable for me to carry wherever the patient was available. For again getting that patient from the ward to the department for doing H reflex, so that was one feasibility issue which I had faced. So that's why I did not consider H reflex here.
Okay, and one more thing, the inclusion criteria, you have something called as cognitive level MMSE pay, 21 or above something was there.
Yes.
So will it not give us a ceiling effect, because 21 and above is already, there's only mild cognitive impairment or something. So what changes would we expect?
Ma'am, mild I considered because the patient should be able to feel the current, because whatever I am explaining about the exercises as well as this modality is directly using the current on the brain or the lesion of the patient. So any adverse effect or anything which would cause further damage to the patient, he should be able to cognitively be sound to give me back the feedback. So that's why I did not consider very less amount of cognition. So that's why I consider little, like those who have mild were considered for me. So it's better for understanding. Yes.
Thank you very much. That is
Thank
very
you, ma'am,
nice
for
presentation.
Yes.
And
Thank you so much.
I have just a couple questions. The first thing is, from your study, I'm not sure that, do you have any exercise or any training combined with the TDCS?
Yes, sir. I had combined the lower limb exercises with the...
with four groups, right?
Yes,
for
sir.
all of them?
For all the groups.
So, can you give me just a reason why don't you have like the sham or the control group to see that the sham group or the control group?
Yes.
To see that it's not effect from the exercise?
They were given the exercise, only TDCS was given as a placebo effect. So the current was not actually started.
So you have TDCS for 4 group, right?
Yes, sir. It was same for all the groups, and conventional physiotherapy was continued for all of them. Yes, sir.
So, and when you want to see the effect of TDCS,
yes.
My question is, why it might be better if you have another group as a sham for control exercise alone.
Okay.
to see that the effect from the result that you had that come from TDCS. Okay, that is
Okay,
my
okay.
first point.
Okay.
And the second point is, did you check for the minimal clinical important difference?
Sir, I did not get.
The MCID, because actually for the statistical analysis, it shows something different, but it doesn't mean that it's going to change in the
So
clinical
can you
practice.
just please repeat
The MCID,
Okay.
minimal clinical important difference.
Okay.
So it might be later. You can check it with that.
Can you just like highlight a bit on that? Like I would incorporate in my further studies if you are taking it.
Yes, so you just go back to check about the definition of all of your parameters
Okay.
and see that in the clinical practice, how much different compare between pre and post. Gonna say that this is a significant difference in the clinical practice, not just a statistical analysis different.
Okay.
Okay, thank you very much.
Okay, thank you so much. Sir, just one thing I just wanted to focus, like TDCS gives, it is given for 2 milliampere, which has been
Thank you,
studied
ma'am.
that it is ideal for all patients. So we can use it considering the exclusion criteria. So,
Thank you
thank you
so
so
much,
much.
ma'am.
Sir. Thank you, ma'am.
Now we are
The thing that sir was also trying to highlight was there is MCID given for all the outcome measures.
Yes.
If a modified Ashworth scale score from 0 goes to 1 or 3, or from 3 to 1 or something like that, then it shows that it's a clinically change is there.
Okay.
So that is what sir was trying to say you, ki if MCID is considered before choosing the outcome measure, I mean it should be known to us कि ये outcome measure के लिए इतना MCID है, तभी हम बोल सकते हैं कि there is a change. And that's the same thing I was trying to highlight is that sensitive to pick the change also. So that even we can see कि MCID achieve हुआ है या नहीं हुआ है. That is what sir's
Okay, like for
thing
all
was.
parameters,
Yes,
I would have
all
done an
outcome-
MCID
yeah,
check. Okay.
All the outcome measures MCID is already been given and it is published. It is out in the public domain for all the outcome measures. That is what sir was trying.
Thank you so much, sir. Thank you for the
ma'am.
suggestion. Thank you so much. Thank you, ma'am.
enjoy the meal. We will resume the session promptly at 2 p.m.